Hello, bonjour, hola, salam alaikum, and a warm welcome in whatever your native tongue to day two of the fifth MSF Pediatric Days. Yesterday, we heard some fantastic presentations centered around the theme of Together for Better Care, and especially the importance of initiatives that address the health and well-being of both mother and baby, and interventions that have been proven to dramatically reduce newborn mortality, early skin-to-skin care, breastfeeding, and psychosocial support. We can only hope to achieve these interventions if we keep mothers and babies together. And to do this requires the input of all team members, clinical staff, health promotion teams, logistics and operations, and most importantly, mothers themselves. And a call for action to aim for zero separation, keeping mothers and babies together wherever possible. Today's theme centres on the topic of prevention is better than cure. We'll discuss some of the field-based strategies on the detection, early management, and prevention of some of the most important health issues affecting our paediatric patients. This afternoon's session and panel discussion will focus specifically on malaria and related prevention and control strategies. We'll be prompted to see health through the lens of planetary health and explore the inextricable links of the changing health of our planet with the changing health of its people. Just a few reminders. So there are several spaces that can be accessed via the main lobby. Live sessions will be screened in the auditorium where we are now. You can access the auditorium in French or in English. And to change the language, you can click on the tab on the left-hand side of your screen. To the right of your screen in the auditorium, you can find 4 tabs. The chat function, you can feel free to say hello in your own language if you like. Let us know where you're joining from and let us know if you're joining in a group. If you are joining in a group, we'd still encourage you to register individually so that you can access the full functionalities of the platform. Importantly, the next tab is the Q&A tab. So remember to post your question to speakers here and not the chat function. Unfortunately, we don't have time for all of your questions, but make sure you reach out to speakers via the chat function during conversations over coffee in the break, or try to find them in the networking lounge. The third feature we have is the poll feature. So during this afternoon session, you'll have the opportunity to participate in audience polls. A question will be posted here in both English and French with multiple choice responses. So let's give that a try now. Our question today is, are you wearing socks today? So let's find out who's wearing socks. So we can see that more than half of our audience are wearing socks. So remember to use this function in this afternoon session. Then there's a notes feature where you can make a note to yourself for reference later on. There are a number of other fantastic features of this platform which I'd encourage you to make use of during the breaks. So we have a poster hall, the booths or a resource library where you can find out more. There's also a fantastic feature called the networking lounge. And if you're not in conversations over coffee, I'd encourage you to go here. I joined yesterday and managed to connect through video call with several other people in the conference. We'll move now to our first speaker for today. So our first speaker is a giant in the world of global paediatric health. We have the great privilege to be joined this morning by Dr. Zulfikar Bhutta. Dr. Bhutta is the inaugural Robert Harding Chair in Global Child Health and the co-director of the Centre for Global Child Health at the Sick Kids Centre in Toronto. He's also the founding director of both the Centre of Excellence in Women and Child Health and the Institute of Global Health and Development at Aga Khan University. He has numerous other affiliations across diverse geographies. He's a leading expert in maternal, neonatal, and child health research, and he has been recognised for his major contributions to advancing global paediatric health as the recipient of the 2021 IHME Rue Prize and was recently awarded the John Dirks Canada Gairdner 2022 Global Health Award, one of the most prestigious awards in global health. It is my great pleasure and honour to introduce Dr. Bhuta, who will give today's keynote address on the impact of climate change on global child health.
Ladies and gentlemen, good afternoon, good evening, wherever you are. I'm very grateful for the opportunity to speak to you today on a topic that concerns many global health community members, as well as pediatricians and practitioners all across the world. And I'm very happy to speak to you today about the issues that relate to the impact of climate change on child health, and also on issues that transcend boundaries and particularly affect children in some of the most deprived sections of the population. What I hope to cover over the next 20 minutes or so is what is the role of climate and climate change in the context of particularly global planetary heating. I'll talk about consequences and the impact of climate change in the context of women and newborn infants, also on infants and children, and particularly around their nutrition impact. And I'll talk to you a little bit about the evidence from Pakistan, and hopefully we can then finish with a quick insight into how we can, as a community of public health practitioners, help. So the first point to drop home is that climate is, as a context of averaging of weather over a long period of time, a highly complex system. And when we talk about climate change, we normally talk about climate change in the broad context of centuries, if not more. So if you look at the context of the last 1,500 years, there has been evidence of gradual warming, but then over the last 9,000 years, things had been particularly stable. But the last century has seen a pretty rapid rise in global temperature, exemplified by this picture of a glacier in Alaska, which within the last century has not only disappeared, has been replaced with a lake. And although this may not necessarily represent a crisis in terms of the geography that I'm showing you, this disappearance of glaciers from many parts of the world represents a huge crisis at this point in time. I come from Pakistan, home to some of the most numerous and largest glaciers in the world. So out of 7,000 glaciers in Pakistan, the rate of melting is alarming, to say the least, and that will have existential consequences for many people living in that geography. When we talk about climate change, what we are largely concerned with is the greenhouse effect that comes from a broad accumulation of CO2 or carbon dioxide in the atmosphere, which normally converts the protective effect of what we have with the atmosphere protecting the Earth from heating too much to a circumstance where we have a rate of change of temperature, both surface and also subsoil temperature, quite significantly. And if you look at this in the context of, again, the time periods that we've been referring to, the last 60, 70 years, you'll see that the rate of rise in the last period between 1950 and today is virtually exponential. And some of the 10 warmest years in record have been seen within the last decade. This particular year, which is still underway, has seen some of the record temperatures recorded in various geographies, including South Asia. This matters, not just because of the overall impact, but the impact that it has on extreme weather events. So a small shift in temperature also shifts the curve to the right. And not only do you have average warming, but you also have great propensity to extreme hot weathers, just as global cooling, if anything like that existed, would also have an impact in terms of extreme cold events. The impact of this in gradual context over time, as I've just mentioned, on many of our reservoirs of ice and glaciers is enormous. Not only do we have increased melting and disappearance of these glaciers, but there's also, by virtue of these changes in atmospheric temperature and surface temperature of the sea, increased levels of precipitation in many parts of the world. This year, in some parts of the world, we have seen record levels of rainfall that have never been experienced before. Just today, in Saudi Arabia, you wouldn't associate Saudi Arabia with an impact of climate change in the opposite direction. But we've had around the Red Sea record rainfall with close to around 400-500 millimeters of water precipitating within a period of 24 hours. So these things are happening right in front of our eyes with changing weather patterns and changes in patterns of precipitation, both on the higher and the lower side. But what we are particularly concerned with is these extreme heat events. And this is an exemplification of the kind of extreme heating that can occur in certain circumstances, notably in large population settings, where a mass of warm air can build up and accompanied by high pressure in the atmosphere can create a dome which over a period of time in a particular population can lead to extreme retention of heat. And you see some of this consequence in urban settings, particularly in South Asia and the mega cities, with virtual weeks and weeks of extreme heat, which does not seem to dissipate or go away. How can this impact health? So climate change can impact health in several ways, both direct and indirect. The direct effects of climate change, as I've just alluded to, increased melting of glaciers, increased propensity to floods, as well as the converse of disappearance of subsoil water and drought, both are happening in front of our eyes. It is sufficient to note that a lot of the disasters related to precipitous melting of glaciers and some of these glacial lake outbursts have happened over the last 10, 15 years. The indirect effects relate to what can be the impact on both subsoil, water, land use, agriculture, water quality, but also on the impacts that we're beginning to see in air quality in many parts of the world, particularly where the particulate matter in the air can go up because of dry weather conditions and lack of rainfall. The social dynamics around some of this change, such as population movements, migration, societal impact in terms of increase in poverty levels, all of those are extremely important. But we are also concerned, and the focus of our discussion today is also on some of the direct and indirect health impacts. Some of these health impacts can be seen in the context of what happens with both a rise in temperature, increased CO2 levels, extreme weather conditions, increased propensity to floods, and all of these impacts that you see with severe weathers, air pollution, increasing allergens, water and food supply impacts can relate to a range of these conditions which are a consequence of climate change. These relate to vector-borne infections that you see an increased proportion of, but you also have higher rates of respiratory allergies, asthma in many populations, as well as impact on malnutrition and diarrheal diseases as we see. Also related to it is the forced migration and civic society conflict. MSF works in geographies in the Horn of Africa. You are seeing the real impact of climate change on some of the population displacements and the impact that it has on services. Over the last few years, we have seen the confluence of the four crises that we now call the crisis complex. First COVID and climate change, then cost of living, and also conflict. The confluence of some of those in many geographies compounds the impact of climate change on health and human development outcomes. Some of the consequences are more subtle and not really notable, and these are the impact that you have on mental health and on some of the issues that many of the young people are confronted with. What climate change and some of its impact on our living conditions and society is doing is taking away hope from many young people that they are going to inherit a world that is not only uninhabitable, but also has not the same quality of life that many of their predecessors have. Behind many of the migration patterns in the world are also some of these existential issues that you're dealing with climate change being behind them. So I mention this in particular because some of the impact of climate change and related to it, the gender inequity aspects are not very well recognized. The mental health stress, strains on social relationships, and also the propensity to stress disorders of the nature that could be akin to post-traumatic stress in many ways. Now, the question arises if this matters. And it really matters in the context of not only global development and monetary terms, but in health terms in very substantive ways. The World Health Organization estimates that between 2030 and 2050, in a 20-year period, there could be an additional 250,000 deaths from diarrhea, malnutrition, health stress, vector-borne diseases. And this would cost an additional $2 to $4 billion per year just in healthcare-related costs. Now, that may not seem a lot overall in the global context, but if you are able to put together all the impacts of climate change through disasters, and a vast majority of those being floods, as well as other geophysical disasters that are related to climate change, then you're talking about all of a sudden trillions of dollars. And we believe that between 1998 and 2017, climate change-related disasters have killed close to around 1.3 million people and leaving many more injured, homeless, or displaced. And the net cost of this, just in this time period, is estimated to be close to around $2 to $3 trillion. And this is something that is not just an issue of high-income countries. We hear about California, and we hear about climate change impact in Canada. But the ground reality is that the bulk of the countries affected by climate change are low and middle income countries. And there, the effects of climate change are compounded also by lack of infrastructure, the lack of the ability to mitigate, also to the ability to provide some degree of adaptation in those communities. And you can see in this, in graph white, quite clearly that the burden in terms of how the impact of climate change will be felt is disproportionate in low and middle income countries, which represent close to around 60% of the global population that will be impacted by climate change. How can I give you an example of this? My own geography, my country of origin. You take Pakistan, South Asia has seen some of the hottest periods this year, 2022, with periods where average temperatures in many rural areas exceeded 45 degrees centigrade for weeks on end. You can't even work, leave alone breathe in that kind of an environment. And then it was coupled with a direct consequence of that, of change in monsoon patterns and what Secretary General Guterres called monsoon on steroids, which over a short period of time poured in water that had never been seen before in some of the same geographies in the south of the country that had seen extreme heat just a few months prior. The end result? 1/3 of the entire population of Pakistan was affected by climate change. And in geographic terms, that's quite a substantial area. Of the 33 million people who were directly affected, many more indirectly affected, 16 million were children, half of them. And of the 1,700 deaths, 600 were reported in children. So you can easily estimate how this disproportionately impacts women and children and the most vulnerable, leave alone the infrastructure that was destroyed. 16,000 schools destroyed alone in Pakistan. And the net cost of this, $40 billion, at least estimated by the government, where the government has been struggling to negotiate loan relief and get resources from IMF at max of $1 and $1.5 billion. So you can imagine that just an event like this pushes a country to a brink of disaster. What about impacts on women and newborns that I've alluded to? Now, many systematic reviews do indicate that pregnant women are at high risk of adverse effects of climate change by virtue of physiology and also by virtue of exposures. They generally, in the low socioeconomic groups, women don't have the choice of not working because they are also housemakers and they work in the fields. And they typically work in some of the hottest days of the world, of that region. Women also go and fetch water in many of those places. You can't fetch water in dark. And most of these women are therefore exposed. And if they are pregnant, their exposure is compounded by the physiological impact of extreme heat. Some of these climate change impacts are particularly notable in pregnancy. As you can see, it is not only just the direct effect of heat on in utero physiology, energy transfer, risks of preeclampsia, but also on the impact that it has on stress, mental health, and indirect effects due to undernutrition and vector-borne infections. The end result of all of this is that several studies have shown that exposure to extreme heat increases the propensity to have low birth weight or reduce intrauterine growth. And you can see this very clearly here, that if on the y-axis is the change in birth weight, you can see that with increasing temperature, you see an impact in reducing birth weight, particularly around middle of the gestation. And this impact is strongest in mothers who were homeless in this particular study. So it is the poorest of the poor who have this impact. You also have, through several studies, this is a meta-analysis of studies from Africa, where if you look at prematurity rates and exposure to extreme heat, there is a pretty significant increased odds of preterm births, as shown in this slide, around 1.04 to 1.05 with every degree increase in temperature. And this can be quite significant at a population level once you translate that into numbers. The causes, the etiology of why this happens is through the impact of extreme heat on physiology and the fact that extreme heat can overcome any regulatory mechanism, particularly in pregnancy, around dehydration, around endocrine dysfunction, and compromised placental function. The end result of all of this is that it impacts not only maternal health during pregnancy, but newborn health. These babies who are born prematurely or are born small have impacts that can extend way beyond just the newborn period into infancy and lead to higher odds of both mortality and also impact in terms of neurodevelopmental consequences. This has been also notable in terms of additional stresses that these women can have. And this is the confluence of different manifestations of climate change, not just of heat, but also if you are compounded by indoor and outdoor air pollution, that can increase the propensity of not only stillbirths, but also low birth weight in itself. It was estimated just a decade ago that the air pollution associated preterm births were about 2.7 million, 18% of all preterm births globally. So just imagine a poor woman in a rural part of South Asia, exposed to extreme heat, but also forced to live indoors, and most of the kitchen facilities are indoors, also exposed to indoor air pollution. And if the air quality outside is also poor, this is the confluence of compounded risks due to climate change, direct and indirect effects that have a direct impact on birth outcomes and pregnancy, and notably also on maternal health outcomes. Impacts on infants and children are also well documented. Some of them are through a direct effect of climate change and disasters on propensity for diarrheal illnesses. The impact of El Nino on childhood diarrhea is very well established. Maybe some of the strongest evidence of impact on infants and young children has been noted from studies done in Europe. This was the data from Catalonia, where they estimated that during the warm seasons of 1983 to 2006, during the extreme hot periods where this was documented, they documented a 50% increase in perinatal mortality. And this effect was observed in close correlation and on the same dates as the extreme heat events were recorded. This is where good data is available. WHO estimates, UNICEF estimates that up to 88% of the existing burden of disease of climate change occurs in children under 5 years of age. And this is because of physiological vulnerability and other factors. UNICEF estimates that close to 1 billion children would be at increased risk of climate change-related crises. We believe that these can be compounded by natural disasters, the stuff that I've just talked about, like floods and others. And many of these children live in not just floods, but in the opposite, in the extreme drought zones. At the moment in Somalia, what is happening with a lot of these refugees escaping virtually drought conditions, famine conditions, the impact on children and women is just visible to everybody who is seeing the images come from there. And the projection of these deaths are not trivial. I've already given you a figure close to around 250,000 between 2030 and 2050. And just in the year 2030 alone, WHO estimates we'll be dealing with close to around 77,000 to 131,000 additional deaths due to children and due to children being affected by climate change. I want to speak briefly about something that we know a little more about than infectious diseases in relation to climate change, and that is nutrition. So it stands to reason that there are many things that farm to table are impacted by climate change. Climate change's effect on water security, on agriculture production, micronutrient content of crops, and just basically reduced food security in a given population. That has been well documented year after year after year. What we know in terms of numbers is that the correlation between food insecurity and additional childhood deaths due to malnutrition is very well recognized. But what people have been able to model and say is that the impact in terms of long-term malnutrition outcomes, such as stunting in children, are underappreciated. And the European Environment Agency has been able to give some figures as to what they project to be due to climate change impact on agriculture yields and as additional risk of stunting in children. I can give you some data on that because we have worked on this in Pakistan recently. And if you look at Pakistan, I look at average rates of precipitation. There is reduction in rainfall towards the south of the country. If you look at average volumetric soil water content, that has gone down. And you also see an impact of food security of this increased heat or climate change related changes in surface temperature over time, which are largely towards the south of the country. Now, the question arises, how does it matter? Does it really contribute to undernutrition in children? And in our model, when we did this Oaxaca blinder decomposition with all of the known risk factors thrown in, there are clear associations of linear growth retardation, as well as improved height for age Z-scores, with things like economic improvement, improving growth, maternal education, improving growth, food security improvement, improving growth, and also growth improves if your size at birth increases and if your maternal BMI goes up. But look at the converse. With average increase in temperature, surface temperature, and also reduction in soil water, you have the total converse effect in this multivariate model on child stunting. So in Pakistan, child stunting is clearly not only related to these short-term things like food insecurity and poverty, but also these long-term impacts that we are seeing in terms of relationships to climate change. What can we do about it? Now, first is a question of collective responsibility and advocacy, which is why I'm speaking to you today as MSF. What role can pediatricians, pediatric association, and civic society organizations like MSF play in this? There is a clear reason to walk the talk. Given the disproportionate impact on children, all of us need to become very strong advocates. And even though we may not be an expert, but we need to be aware of some of these consequences and speak to this wherever we work. It is quite reasonable for us to adopt strategies to reduce the carbon footprint of our own organizations. It is also quite reasonable for us to look at adopting technologies and processes which reduce waste and also increase the greening and the impact that it indirectly has on climate change globally. Now, I'm not for a moment assuming that all of that would lead to any impact substantial, which would be different from what we are asking the rest of the world to do. The world needs to do a lot more. But in our advocacy is also the opportunity for us to do a lot more in terms of mitigation. And let me point out to you where we can work together to improve the evidence base around what we can do for women and children globally. This is a recent exercise that my group has done with, in this particular instance, global funding bodies, to look at what is the evidence around interventions that can reduce some of the impact of climate change at population level. And guess what? Whether you're looking at climate hazards and interventions for a variety of areas and issues, the least evidence that we have is around pregnancy, birth outcomes, nutritional interventions in those areas. So I'm seeking at this point in time a lot of support in terms of improving that evidence base by innovations, by operational research, by learning more, by doing more in terms of adaptation and improving resilience at a population level. So clearly, as part of our work, research is important to look at efficient and low-cost interventions to mitigate the effect of things that we are seeing now and today without waiting for the COP27s of the world to come up with long-term solutions that will take time. That should happen. But the poor people of this world need something right now as we speak. And those are around these innovations and low-cost interventions that we are trying to do the synthesis in terms of evidence collation and bring to the fore. We also need to focus on areas where there is very little work. And I've already pointed out to you that around maternal, newborn, this early childhood, this is the area where the impact of climate change has been very poorly documented. And the same is true for elderly and the most vulnerable in low and middle income settings. And I think there is ample opportunity to work on things like gender inequities that we see in relation to climate change, mental health issues, and also improving nutrition through innovations, not just focusing on the already extremely malnourished children. Of course, we need to do something around treatment, but also on prevention of some of these aspects in the very geographies that we serve. So thank you very much for your attention. I'll be very happy to take questions in due course at the time when there is a Q&A session. Thank you.
So quite an amazing summary of the evidence to date. Lots of food for thought and a lot to take in. But Zulfikar will be joining us in our second break at the end of the day during conversations over coffee. So I'd encourage you to head over there and ask any questions you have at that time. We'll move now to the oral presentation. So a reminder that there's 7 minutes of presentation and then 3 minutes for questions. Remember to ask your question in the Q&A tab. Unfortunately, we won't have time to answer all your questions, but you can reach out to speakers during conversations over coffee or using the chat function. So our first speaker today, I'd like to welcome Gabriele Rossi. Gabriele is a paediatrician and public health professional who's been working in the humanitarian field since 2005. He spent 13 years with MSF as medical coordinator and emergency coordinator and joined MedAir in 2017. And since 2020, he's held the position of Global Health and Nutrition Advisor. His presentation is the predictors of wasting by the age of 1 year among infants under 6 months enrolled in a MAMI program in Cox's Bazar refugee camp. Thank you, Gabriele.
Thanks to you. Hello to everyone. Today, I am going to share with all of you the finding of a study conducted by MedAir in Cox's Bazar refugee camp on predictors and risk factor of wasting by the age of 1 year among infants under 6 months enrolled in a MAMI program. What is MAMI? MAMI is a relatively new program which stands for Management of at Risk of Mothers and Infants and targets specifically the infant small and nutritionally at risk with the final goal of improving survival and thriving. And in this context, the primary objective of our study was to identify a risk factor associated with the onset of acute malnutrition in children already discharged from MAMI beyond the age of 6 months until the age of 1 year. This was possible because those children were admitted straightforward after MAMI in the blanket supplementary feeding program. We call this BSFP. This was implemented by MedAir in Cox's Bazar refugee camp, and therefore we were able to follow them up in a systematic way. This was an observational longitudinal study, and the enrollment period was from January 2020 until April 2021. The last follow-up was in March 2022. The variables measured were weight and age at admission and discharge for the calculation of the so-called weight for age Z score. The main admission criteria or enrollment criteria for MAMI was a weight and age Z score less than -2. The other big admission criteria was feeding and breastfeeding problem. We also measure MUAC at admission and at different time points at discharge, as well as 6, 9, and 12 months of age, as we said it before, in a systematic way. Acute malnutrition for children between 6 months of age and 1 year was defined as a MUAC less than 125 millimeters. We were able to obtain data for almost 500 children, in particular 497. 246 were enrolled in the weight for age Z group, which is a weight for age Z group less than -2, and 251 children were enrolled in the breastfeeding problem. We call this adults group. An additional 41 children were admitted because of maternal problem. These 41 children were not included in this analysis. Let's see here a bit the patient characteristic for the two groups. And we see that the proportion of female patients for both of the groups was similar, 54% in the weight for age Z group and 52.6% in the others group. As well as the age at admission was quite similar without any statistical difference, 62 days for the weight for age Z group, and then almost 52 days for the others group. The myocardial admission was different. And then we see here for the weight for age Z group was 10.6 centimeter. And then for the others group was 11.5 centimeter. Finally, the proportion of children that beyond the age of 6 months develop acute malnutrition was absolutely different, with almost 27% in the weight for age Z group versus the 14% almost in the others group. This yielded a P of 0.007 and the odds ratio of 2.59 in favor of, indeed, the weight for age Z group. Because the weight for age Z group held this higher risk of developing acute malnutrition, then we did run a sub-analysis for this group to identify possible risk factors associated with developing acute malnutrition beyond the age of 6 months and by the age of 1 year. And we saw that male sex was associated with a lower incidence or risk of developing acute malnutrition, as well as age at admission, 51 days versus 91 days, was associated with lower age at admission, was associated with a lower risk of developing acute malnutrition. As a discussion, we can say that weight for age Z group was more prone to develop acute malnutrition by the age of 1 year compared to others group, what we have seen in our study. Weight for age Z infant enrolled in MAMI at an early age show a significantly less risk of developing acute malnutrition later in life. Female sex was associated with increased risk of developing acute malnutrition by the age of 1 year. This was seen both in the weight for age Z group, as we have shown before, as well as in the other group. Some limitation, a small sample size, in particular for the weight for age Z group, and the short follow-up period, better would be to have a follow-up period until the age of 2 years to cover the first 1,000 days of age. The weight for high Z score was not measured due to COVID-19 restriction in the camp. Finally, as a conclusion, what we can say? We can say that effective early screening at a community level of infant as early as possible, ideally before the age of 2 months, to identify those in need of MAMI support may reduce the risk of developing acute malnutrition beyond the age of 6 months. The use of MUAC only for the diagnosis of acute malnutrition in the children more than 6 months, until the age of 1 year, could have favored the detection of female patient over male patient, as we know that MUAC is more sensitive to detect a younger female malnourished patient. A question for reflection which was not addressed by the present study, but maybe is worth of indeed future study. Is it advisable to provide some form of specialized supplementation, for example, lipid nutrient supplement, to the weight for age Z infant is discharged from MAMI, starting from the age of 6 months, to mitigate the risk of future acute malnutrition? We would like to thank Work Concern and SHED for their critical contribution to this study and to all of you for your attention. Thanks.
Fantastic. Thank you, Gabriel, for that presentation. Such an important area of research and one that we're learning more about. I'm waiting for any questions to come through, but I might just ask you, so you compared weight for age Z score and those already with feeding problems. I mean, I guess the effect, if you compared weight for age Z score with the general population, I guess you'd expect to see an even higher effect.
Yes, the weight for age Z score is something that indeed is very much today's study in MAMI as a new or recent admission criteria for enrolling these children, because it has been seen from a recent study that the children that already develop some form of wasting, in particular during the first 6 months of age, have a higher risk to develop as well by the age of 24 months, as well wasting and stunting. There was a particular study done by Mertens in 2020 with following 13 cohorts of children between the age of 0 to 24 months, showing this increased risk of developing acute malnutrition by the age in particular of 18 and 24 months for those infants that already in the first 6 months has some form of wasting defined by weight for age Z score less than -2.
Okay, thank you very much. We might move to our next speaker. So thank you again, Gabrielle. We'll move now to our second speaker of today, so Marta Iskler. So Marta is a nurse by training, and she's worked with MSF at field and headquarter level since 1996. She has a degree in public health and tropical medicine in developing countries, as well as a master's degree in simulation for healthcare, and is a member of the European Society of Simulation in Medicine. She's currently the MSF Field Simulation TIC Program Manager, aiming to operationalise the use of simulation and use simulation as part of the quality improvement process. Her presentation is entitled MSF Field Simulation, Incorporating Simulation into the Plan, Do, Study, Act cycle for an integrative improvement of the OPD triage system in Pulka, Nigeria. Thank you very much, Marta.
Thank you, Joanna, for this introduction, and good morning, everyone. It's a pleasure to be here today to present this experience about incorporating simulation into the Plan, Do, Study, Act cycle for this integrated improvement of the OPD triage system at Pulka level, Nigeria. Simulation in healthcare education as a teaching tool for increased competence is well recognized, but its role when it's used for quality improvement is less known. In fact, simulation it's a versatile methodology that, when it's used for quality improvement, it's very powerful. When we were in Pulka, the team raised that there was a problem of late detection of critical ill pediatrics and adult patients presented to hospital level OPD triage. It means the rare cases were frequently missed at triage level and were identified at consultation level. From MSF Field Simulation, we propose to use simulation to understand, analyze, and address this problem by incorporating it into the Plan, Do, Study, Act cycle. The PDSA is part of the universal and recognized model for improvement, and it provides a foundation for an attitude of continuous improvement. What we did is to, in the integrate simulation in the different phases, we use simulation to analyze and plan design improvements. At the level of Do, we use simulation to embed best practices. And at the level of Study, we use simulation and structured debriefing to test and study the changes. In fact, what we did is combine quality improvement processes and simulation. In the plan phase, we use tabletop simulation, which is a low stress simulation exercise that allows teams to analyze, design, and plan improvements and complete the cause-effect diagram. And the team itself were identifying the areas of improvement. They design and define the solutions, and they make these improvement plans. At the level of 2, the improvement plans were implemented, and including 6 educational simulations on the triage tool chosen, which was the Interagency Integrated Triage Tool. At the level of the study, tally sheets were implemented, and also we observed how the team were implemented the new triage tool after the simulation, the educational simulation, and also we ran some structured debriefing at the workplace during the implementation of the new triage processes to make the adaptations needed. At the end, the triage process was established, and after this positive experience, the team itself were interested in using simulation for the preparation of the malaria peak period, because they were worried because the number of patients was 3 more times, and also because even the identification of critical cases were also even more difficult. Then we repeated the processes. We repeat another tabletop simulation exercise, and also at the level of the study, we did a walkthrough simulation, including the community, to be sure that the perception of the community were considered in the design of these new triage processes. At the end, simulations implemented the problem analysis, facilitating the causes identification and the definition of the improvement plans at the level of the space design, the team composition, the task distribution, the design of the processes, and also the staff competence. And although we didn't have baseline data, the post-intervention data showed a high functional triage system, because from 4,331 patients triaged at OPD for over 30 days, were identified 59 red cases, and from these 59 red cases, 96.6% were identified at triage level, which was the purpose of that intervention. And from that 25 25 points observation checklist, we observed that the staff completed between 96–100% correctly. And the most important is that the team itself were decided or were chosen simulation to design and analyze the triage organization for the oncoming malaria peak. The conclusion is that simulation is a powerful tool that can be used to drive quality improvement processes. In this situation, the simulation helped to redesign, to test, to adapt a new triage system. Incorporate simulation in the PDS a cycle is feasible. It allows teams to identify and implement improvements and test and study solutions. And it's very motivational because it involves the staff on designing these improvement plans. And what is important, it can include the user's perspective on the design of these quality improvement processes. Thank you.
Thank you, Marta. I don't need much convincing myself, and I'm fascinated by the intersection of training initiatives and especially simulation with the quality improvement process. And I think anyone who's worked in simulation will understand that performance gaps are rarely just an issue of pure knowledge gaps. So exploring systems-based factors is really important. And I think the learning by doing aspect allows the team to discover systems level problems. Just going to the questions. Trying to see there were some questions there. I don't have it's not popping up for me. While I'm waiting to do that, I just wondered myself, what is the reactions of your staff to this? How did they react to this whole process?
No, the reaction was positive because it's themselves who decide to repeat the processes for the upcoming malaria peak. They were so positive results, and they were so engaged on quality improvement process because they were part of it. Themselves, we want to do the same for the upcoming malaria peak, which was great.
Yeah, great. And so I've got some questions come through. The first one is, how did you include the community in the design and testing of the triage process?
What we did after the tabletop simulation exercise, that it was a work done with different people involved in the triage system and also in the management department and the managers. During the walkthrough simulation, which is kind of a full-scale simulation, and we invite the community to participate in this full-scale simulation in order to get their perspective, how they were seeing this new triage system for the upcoming malaria peak, because normally they are the users during the malaria peak, and then there will be a new processes, a new flow, and we wanted to get their perspective, and they were really, the feedbacks were very positive from their side. They see that, because also the idea was to reduce the waiting times for them.
Yeah. Okay, there's a whole range of other questions that have just come through, and I think we won't have time to ask them all, but I'd encourage you to go and speak to Marta during the break and ask all your questions at that time. Thank you again for joining us this morning, Marta.
Thank you.
Okay. Moving on to our third speaker, We have with us Kevin Lazmi. Kevin is an MSF nurse who recently graduated with his Master's in Global Health from Karolinska Institute. He's currently working in neonatology in Sweden and with OCBA's Neonatology Community of Practice. His thesis, which is written in collaboration with the Malaria Consortium, is the subject of this presentation, which is entitled The Implementation Quality of Seasonal Malaria Chemoprevention, a qualitative study exploring the perspective of caregivers and community distributors in Burkina Faso and Chad. He'll give his presentation in French. Thanks, Kevin.
Bonjour à tous et merci beaucoup pour l'invitation.
Hello everyone, thank you for having invited me. I'm going to present to you a study that has to do with the implementation quality of seasonal malaria chemoprevention. This is a qualitative study that explores the perspectives of community distributors, parents, caregivers in Chad and Burkina Faso. So, trying to move on to the next slide. Oh, here we go. So let me talk about seasonal malaria chemoprevention. It is a malaria prevention strategy that has been implemented since 2012 in the Sahel region. It administers on a monthly basis a preventive treatment against malaria, sulfadoxine, pyrimethamine, and amodiaquine once monthly during the rainy season to all children aged 3 to 59 months. So the objective is to increase the treatment and prevention in those children. So SMC prevents 75% of malaria cases, simple cases and serious cases. It is a cost-effective approach, less than $4 per child per season. So this strategy relies on community distributors that are going to go door to door and distribute doses of SP and AQ of the direct administration to the children on day 1, and it's given to the parents who administer the treatment on day 2 and day 3. So MSF was a pioneer in the implementation of SMC since 2012. So back in 2012, SMC was distributed to 33 million beneficiaries in 2020. And nowadays, we have 33 million beneficiaries. You have the map on the screen. Since June 2022, the WHO has extended its recommendations for SMC. Now there are many new geographies that are going to be able to implement it. There are no longer geographical restrictions, so all countries can adopt the strategy now. There are also new preventive approaches that are possible with the RTSS, the malaria vaccine, and we've seen that both approaches are having a positive impact. So with those prevention programs, we've seen that very little research has been carried out in order to assess the quality of those SMC programs. So the Malaria Consortium that implements SMC programs in several sub-Saharan countries has developed quality standards in order to make sure that those programs were consistent and were of good quality. You have a list here on the screen. So planning, supply in SP and Q, supply in material, awareness raising, training, distribution, management, supervision, monitoring, and protection, for example. So those are the pillars of this strategy, and those standards have been used in order to analyze the situation. It's what we did in this study. We wanted to develop a better understanding of the quality of the implementation of those SMC programs via the lens of community distributors and parents caregivers. And this has been done for Chad and Burkina Faso in 2019. And we are mostly focused on the barriers to good implementation of SMC. As for the method, this was an exploratory qualitative study. We collected secondary data that have been collected during 2 operational research carried out in Chad and Burkina Faso, 16 group discussions in total, so interviews with community distributors and caregivers. And during the primary analysis of the data for both studies, we realized that many issues had to do with quality, and using new quality standards could be a good thing for this corpus. Now, let's talk about the findings. We have identified 8 subtopics that were associated with quality standards. You have the on-the-screen planning, awareness raising, and community engagement, and distribution of SPAQ. Now, let's talk about planning. The rollout schedule. This is something that was quite interesting. It was discussed in Burkina Faso. It was seen as being suboptimal because the rainy season was considered by the participants. They thought that it would start earlier than the actual campaigns. Now, as for the working conditions of community distribution, this was discussed at length. They said that the working conditions were quite harsh because they were experiencing difficulties in being paid, high workload also. But in both geographies and in both contexts, they were quite motivated. They wanted to do their job because they really had the feeling that they were making a positive contribution to the well-being of their community. Now, regarding awareness raising and community engagement, we realized that the acceptance and understanding of SMC was different depending on the context. So in Burkina Faso, it was rather well understood, whereas in Chad, the difference between preventive intervention and cure wasn't necessarily well understood by the parents, the caregivers, and sometimes even by the distributors. As for the side effects, they were discussed at length in both contexts, and people found it difficult to accept the intervention. There were also concerns and rumors, especially in Burkina Faso, where there were some rumors associated with the side effects. Some people were saying that this was on purpose, so that parents would then go to the healthcare centers and would have to pay for that care. In Chad, people were concerned about infertility, so this was one of their main concerns. So also taking into account roles and gender-based responsibilities. We're talking about geographies where mothers and fathers have very distinct roles. The fathers used to be decision makers. They play a role in the acceptance process, and mothers have an administration role. They would administer the treatment. And we realized that in Chad, the awareness raising of women or the education of women, mothers, wasn't really efficient because they were not necessarily involved in the community distribution level. As for the distribution of both products, well, in both cases, we noticed compliance or adherence issues. I will have to move a bit faster. I apologize for that. I had to prepare some quotes for you. You'll be able to read them afterwards. They're quite interesting indeed. So what are the main topics that were discussed? What adherence? So just as difficult to have under control. Quantitative studies have shown that there is a good adherence, a good compliance. But other studies have shown, especially studies about the pharmacokinetics, have shown that adhesion to SMC could be quite low, only 20% for the Fortune, especially in Niger, for example. So still some work to be done here. So those are some of the main concerns. And people were still worried about side effects. So it's important to engage communities more. Gender also is important. Little research has been done on those gender-related issues. It's important to develop research in order to mobilize the people while taking into account the specific roles of each parent. And there's also the retention of community distributors. This indispensable mobile payments nowadays allow us to pay them in a better and faster way. So thank you very much. I'm done. I will be happy to answer any questions. Thank you.
Merci beaucoup, Kevin.
Thank you so much, Kevin. Thank you.
coverage, but so important to look at the quality of that coverage. And so a really interesting element of research. We've got a question that's been posted. Someone's asked, I'm wondering if the monthly administration of CPS will not result in another fees for household. If so, is it really cost effective?
Est-ce que vous pouvez répéter? J'ai pas compris, désolé, Jéwan.
Can you repeat the question, please? Sorry, I was supposed to ask the question in French. I have forgotten. So I was just wondering whether the monthly administration of a SMC wouldn't be an additional cost for families. Well, SMC is distributed for free. I forgot to mention that. So it's at no cost. This is one of the main principles of SMC. It's not billed to families. Okay, so second question. In your view, should we work on improving the compliance, the adherence? How can we do this? Is this key for the program? Well, indeed, this is one of the discussion items of this study. SMC program is no direct administration for the first dose, and the second and third doses are being administered by the parents' caregivers. And the study really shows that, I mean, there were many uncertainties regarding adherence. Some parents said that they would administer the drug. Others would say that they would keep the medicine for themselves or for neighbors. So I think some work really needs to be done to really improve that compliance in order to monitor things and follow up things better. When we do assessment reports, usually those reports are actually self-reports. And really, there is a bias, there is desirability bias, and I believe that we will have to look into this further. Okay, thank you so much.
Please find Kevin in the break. We need to now move to our final speaker in the oral presentations. I'm happy to welcome Émilie Laureseug. Émilie holds a PhD in molecular and cellular biology. She has a background in research and development of models for screening and characterization of new molecules for various therapeutic areas. She joined the Pierre Fabre Foundation in 2015 as scientific officer and is responsible for managing research studies, instructing health projects, and coordinating expert working groups. Her presentation is entitled Acceptabilité, performance diagnostique et faisabilité du dépistage néonatal de la drépanocytose à l'aide de deux tests diagnostiques rapides, sickle scan et hémotype type SC au Mali. Merci, Émilie.
I would like to thank MSF for having selected the study for an oral presentation. This thanks to a collaboration between the Bamako Sickle Cell Foundation in Mali, the INSEM, and the Pierre Fabre Foundation. This study aims at assessing the diagnostic performance, but also the feasibility and acceptability of neonatal sickle cell screening of sickle cell disease using two tests, two RTDs, the sickle scan and hemotypes in Mali. This presentation has 5 parts: introduction, objectives, methods, findings, and conclusion. So sickle cell disease, a genetic disease that is due to a hemoglobin anomaly, and it has an autosomal recessive transmission. There are several variants of abnormal hemoglobin. The most well-known one is the SAS1, and this is going to have major consequences, clinical consequences in individuals, especially vaso-occlusive crises that are extremely painful because of the obstruction of small vessels, hemolysis and severe anemia, the necrosis of tissues, and increased risk of a stroke. And the major crisis is characterized by severe forms in SS and SC individuals. This is the genetic disease that is the most widespread worldwide, 300,000 births per year, and 3/4 of them in sub-Saharan Africa. Mortality is estimated to be between 50 and 90% in children under the age of 5 if there is no care provided to them. Fortunately, early screening plus appropriate preventive measures allow to reduce significantly up to 70% the mortality and morbidity. The diagnostic of this disease is done in a lab with all the constraints that we all know, cost constraints, timelines, competencies, human competencies and skills. This is the reason why those rapid diagnostics tests have really changed things around in the area of screening. We are talking about a limited resource setting in Mali, and we need to assess those strategies, those RDT strategies to public health officials. So we wanted to assess the intrinsic and stressing performance of those two RTDs for routine neonatal screening, and we compared it with the standard technique, which is HPLC in 3 maternity wards in Mali, 2 in Bamako. And secondary objectives assessing the acceptability of neonatal screening by families, and also assessing the feasibility and acceptability of those RTDs by healthcare professionals. So we're doing about a 4-month period in 2021. Once the mother had provided her informed consent, all live-born infants were assessed. We collected the blood cord, and based on those samples, we carried out the 2 RTDs and also the HPLC test. So out of over 4,000 women, 84.6% accepted to take part in the study. Only 1.4% said no, and the difference is 15% between the locations. It actually corresponds to either emergency situations, obstetrical emergencies, or because women didn't have enough time to go further. So 300 and 640 children were included in the study. So we consider that based on the data, we have a very good acceptability rate. The chosen scenario has allowed us to study the capacity of both tests to discriminate between the various types of sickle cell diseases. And this study has also allowed us, because we had a good sample, to highlight new prevalence data at both 1.64% of SDM, which is quite important. Now, regarding the diagnostic performance, I would like to draw your attention to the predictive value, negative predictive value of the test, which is of the sickle scan, which is almost perfect, and hemotype also, which really allows us to exclude all individuals who are not impacted by the disease. And now we assume, we see that the positive predictive value is sufficient. Those tests have a good reliance, and it is relevant to use both tests in order to carry out a screening strategy. The acceptability by healthcare professionals was assessed also. 69 people were involved, and this was a self-administered questionnaire. I cannot tell you that 94% would accept to carry out a routine screening if it were invoiced. So those are very good findings. So to conclude, this study was carried out according to national standards on a consequent number of people, and really it was performed on cord blood, which is quite original. So those RTDs are very reliable in order to screen the infants, and this could allow us to implement a screening program at both in a limited resource context. a very good acceptability by the population and also by healthcare professionals. And we also now have updated prevalence data regarding the disease at birth in Mali. So this is a good tool for those resource-poor contexts. And I would like to thank all our partners, including Professor Guindo from DCRLD, Dr. Valériane Leroy, and Valentina Pico, and everyone has taken part in this study also. I'd like to thank you for your attention. Thank you. Thank you so much, Emily. I would like to know, so you said 85% have accepted to do the test. So I'm interested, what about the 15% or so no? Why did they say no? Well, 1.4% refusals. No, the 15% difference between those who signed the consent and the others actually due to obstetrical emergencies, no C-sections, no real emergency situations, or other cases where midwives did have the time to include the mother in the study, which really shows that the relapse rate is actually very, the refusal rate is very low, 1.4%, so good acceptance, okay. Okay, thank you for this presentation. Could you also explain how the tests were carried out? And following the diagnosis, what kind of follow-up or care is being made available to those children? Thank you. Well, thank you for asking the question. I mean, the blood cord is collected at birth, obviously, and the rapid tests are done immediately at birth, in the delivery room, using a small drop of blood for each test. And the technique, the benchmark technique is done afterwards at the research center a few days afterwards. Once the children have been diagnosed as having a major sickle cell disease syndrome, and they receive antibiotics until the age of 5 with penicillin. Vaccination also is essential. And they also receive a folic acid because of the risk of anemia. I can't hear you anymore, sorry. I think we have enough time for one last question. So what is the tool used in order to assess the acceptability by healthcare professionals? Did you use the NICA scale? No, we didn't use that scale. It was just a self-administered questionnaire with questions regarding the ease of use, for example, and the way they perceive things, but we didn't have the scale that you just mentioned.
Merci beaucoup.
Okay, then, thank you so much, Emily. Thank you.
So if you have questions for Emily, any other questions coming through, please feel free to reach out to her during conversations over coffee or take up a private chat. We'll move now to our live demo, and we're going to present the E-rounds. I'd like to welcome Edward Chu. So Ed is the Emergency Medicine Advisor for MSF Amsterdam and Geneva, and he's also the founder of the Berlin Knowledge Lab. He has a bachelor's degree in cultural anthropology and a master's degree in international health system financing, and in a previous life worked in the field of philanthropy, providing grants and advocacy training to grassroots community health projects before he found his calling in emergency medicine. Ed will give a live demo on the E-rounds initiative.
The E-rounds is an activity of the Berlin Knowledge Lab that focuses on bringing distance continuing professional development to our projects in the field. The E-rounds consist of monthly interactive lectures that vary from traditional grand round style presentations to fully interactive simulation exercises with field projects. Let's listen to Dr. Nitya tell us about what she sees as the impact of this activity.
As an example is how they had a webinar on the pathophysiology of shock and how to manage shock. And it was just with simple things, how they could differentiate just by checking the pulse with using just basic clinical knowledge. that they were actually able to take the knowledge that they got from this webinar to actually save a life.
Clinical case-based learning makes up a large part of the e-round activity. In the breakout rooms, we have introduced exercises for simulation to our projects and allows us to really focus not just on presenting information, but helping project staff to integrate it and use it in a case-based approach. Let's see some of the examples of breakout room exercises.
So I'm going to show you the first case. It involves a video, so I'm first going to show you the video. Okay, let's discuss. What do you think? Is it a longitudinal view or maybe a transverse view?
Yeah, what I see here is a transverse view of the uterus.
To see. So you said no spontaneous breathing, yeah?
Yeah, no spontaneous breathing. Yeah, it's no spontaneous breathing.
Yes.
So what we can do now?
It's rescue breathing. Rescue breathing.
Rescue.
Five rescue breathing.
Patient adult with gunshot in abdomen. What do we do?
هل المريض قادر إنه يتمشى ولا مش قادر يتمشى؟ Okay.
The logistics of these activities are fairly simple. Each month, we identify a topic, confirm a speaker, and work with the focal points in the projects to arrange for the participation of their medical staff with the activity. We organize a preparation session where we go over the topic and the interactive activity that we're going to do during the breakout room, and then follow each session with a debriefing with the focal points to see how we can improve on the activity on a regular basis. So as we can see, the focal points are really an essential part of this activity and really elevate it and allow us to do things that are much more engaging than we would otherwise be able to do with a traditional webinar. Each project that participates has to identify at least one focal point to coordinate logistics. They also help to make sure that the equipment needed is there, but their most important role is in animating the activities that happen during the breakout rooms. They're the ones that are there with their team and really put into practice the tools and cases that we provide to really make it more than just an activity of listening to a lecture. Here we hear some feedback from one of our focal points, Duha, who is the medical activity manager in the Adahi project.
About it. And also for the e-rounds, it was really, really so interesting for everyone here in Adahi, especially when we was participating with you. So the guys was holding their books and paper, sitting, together in the room, and they said after that, oh, look, we participating with Jennifer. Oh, someone talked to us.
So I don't think we could say it any better than that. So thank you so much for listening to this presentation, and we look forward to those of you who will be joining us tomorrow for the neglected tropical diseases e-round experience that we are doing in collaboration with the pediatric working group. Thanks so much.
Fantastic. What a great initiative. And Ed will be available during the conversations over coffee break, so you can ask him some questions during the break. We'll now move to our speed posters round.
Good morning. I'm going to present focus on how we can better treat peritonitis cases due to typhoid fever. and we have sometimes non-typical cases. The interpreter is sorry, but there's literally no sound. I just can't hear anything. Focus was introduced in 2021. And it has had a positive impact on our project. And we've noticed that there was an improvement in the overall management of the cases.
Hello, I invite you to come and view our poster titled Magnesium Sulfate as an Adjunct to Treatment of Tetanus in Children. Tetanus remains an important cause of illness and death in children in many parts of the world, and treatment can be difficult without access to an ICU. Benzodiazepines are the main medications used to manage tetanus, but they also carry a risk of respiratory depression, especially in tetanus where this risk already exists. I invite you to visit our poster and hear the story of how the first documented use of magnesium sulfate in an MSF setting came about. Our poster, which includes co-authors Dr. Timothy Pont and Dr. Emmanuel La, describes the use of magnesium sulfate as an adjunct to treatment with benzodiazepines in a case series, showing reduced use of benzodiazepine in an MSF setting.
Yeah, hi everyone. So this project that was implemented in Afghanistan, the three key partners, Ladle implemented this in the remote areas in 10 provinces, where we were able to train the community midwives and their supervisors in the midwifery skills using the digital tools. And I invite you to visit this posters to know how we implemented these various digital tools to train them remotely. And we also do have a few nice safe stories from the field after the humanitarian crisis hit Afghanistan, where Taliban took over. Although the project got over after the humanitarian crisis hit, but then we are still getting these safe stories from the field. So please do visit to get these hear about these few good stories that we have from the field. Thank you.
I invite you to view my poster entitled With a Little Help from My Friends. This case describes a 7-year-old girl with an empyema and recurrent purulent pericardial effusion who was cared for in the MSF pediatric ICU in Herat, Afghanistan. It illustrates the challenges we face with complex cases and the difficulties in diagnosis and treatment without access to bacterial cultures. Our ability to care for her for as long as we did was greatly enhanced by the support of MSF telemedicine specialists over several months. As a relatively new project at the time, we had to explore and develop new working relationships with local specialists. We were fortunate to discover an interventional cardiologist who was able to perform percutaneous pericardiocentesis, which undoubtedly gave this girl some more time. Despite the outcome, we were proud as a team for what we were able to achieve, and it was a pleasure to be able to care for such a wonderful little girl.
Hello, everyone. I'm Cayetana, and we would like to share our experiences of integrating neonatal and pediatric palliative care in Bangladesh. First, we created locally adapted protocols using the MSF palliative care guidelines, and we identified focal points from each discipline. To support program implementation, we conducted an ethnographic study to understand the moral experiences of the staff and a rapid qualitative evaluation of caregiver experiences. We faced many misconceptions among the staff regarding palliative care that we're able to mitigate with multidisciplinary daily bedside clinical mentoring and debriefing of every complex cases. Another big challenge was to face the family preference to take child home, as unfortunately we couldn't offer home-based care. But by understanding the caregiver preferences, we adapted our hospital-based practice and increased the number of families that chose to spend the last moments of their child in our hospital. We offer private space 24-hour visitations, facilitating visits by religious leaders and traditional healers.
Thank you. If you'd like to find out any more about the posters that were rapidly presented there, please head over to the poster section where you have a chance to also reach out to the authors. We're going to move now to our coffee break. So just a reminder of the numerous things that you can do during the next 20 minutes. We have conversations over coffee. So it's there. Edward Chu will be available for discussion regarding the eRounds project. There's also a number of other features of the platform that I encourage you to make use of, and particularly the networking features, which won't be available once this conference finishes. So there's the networking lounge. You can go in there and meet other participants. You can create a video conference. You can join others and join there. It'll come up in a bubble and you'll all be able to chat together over a video call. There's also a number of other spaces. If you're a bit lost, you can go to the help desk and have a look at the video, which explains the full functionalities of the platform. There are booths, is the resource library, there's the chat functions. You can swap cards with other participants, but I encourage you now to make the most of networking with your colleagues. Enjoy the break, and we'll see you in 20 minutes at 15 minutes before the hour. Welcome back, and hope you had a nice break and a chance to interact with some of your colleagues. We're going to move now to a presentation on creating partnerships to improve care, a project on sickle cell disease.
La drépanocytose, c'est une maladie du sang, une maladie génétique, c'est-à-dire héréditaire. Pour que la personne ait la maladie, il faut qu'elle hérite du gène maladie. La drépanocytose, c'est une maladie du sang, une maladie génétique, c'est-à-dire héréditaire. Pour que la personne ait la maladie, il faut qu'elle hérite du gène malade des deux parents. Et c'est une maladie qui est en rapport avec une hémoglobine anormale qui remplace l'hémoglobine normale, ce qui est à l'origine de l'ensemble des manifestations cliniques qui sont caractérisées par la douleur, l'anémie, c'est-à-dire le manque de sang, l'ictère, c'est-à-dire la coloration jaune des muqueuses des téguments,
yellow coloring of the skin, and children are highly sensitive to infection. Management of sickle cell disease is throughout the life of the patient. We provide care to children once the diagnosis has been made. Ideally, the diagnosis is made at birth and after neonatal screening, but we do not have systematic screening. We have here a pilot site and the OPD for children and teenagers is a unit specialized in sickle cell disease, which has been developed throughout a cooperation between Monaco Principality and State of Senegal. And we have staff from MSF who came from training courses for capacity building. Personally, I took part in a webinar to share our experience in this area. And I must say it's a fruitful cooperation where we've improved the skills of the staff in the field while it's not well known in the region. And there was a very good integration of all the teams. Everybody got interested in this program, and I guess they have improved their practice. I work in DIFA. Currently, I have more than 1,000 patients, and I've learned a lot from this secondment to Dakar, to the UPD for teenagers and children with sickle cell disease, how to open and set up a unit to manage the new cases, the various examinations to be made. And this experience had helped me because now we have fewer cases of infection. 78% of the cases were reported to us. Now we're at 30%. Education of patients has also been greatly improved because they know the impact of OPD, the rules to be complied with. So this clinical secondment has helped me to know better and better understand the management of sickle cell disease in children. It's a great team, and I would like to thank you for all this. Generally speaking, the secondment to Dakar has helped to change the management of sickle cell disease in Madarufa because It was for the management of the cases and also for the organization. We have better organized our unit. Our experience has allowed us to improve the physical examination to early detect any complication related to sickle cell disease, and it has helped us to improve the quality of management of chronic and acute complications. It has helped us to better include sickle cell patients and a better management of their pain, but also other aspects. And through this experience, we've learned some experience with the treatment with HU, the contraindication, the doses, the interpretation of the lab examinations, the change in the dosage or the interruption of the treatment, the toxicity and the side effects of the drugs. And this has helped us to start go for this training because it greatly helps the management of sickle cell disease. No sound. The interpreter doesn't have any sound.
So I think we're back on. What a fantastic initiative and a great example of how we can tap into the expertise of our local partners to increase the capacity of our staff and improve the care for our patients. If you want to find out more about this initiative, you can have a chat with Inma Carreras, who's the Paediatric Advisor for OCP, who will be available during our conversations over coffee. The next session is quite dense, and we've been sitting at our computers for quite some time. So I wanted to ask my alter ego to come on. I also go by the name of Renard. My surname is also Renard, which means fox in French. So I'm going to ask Madame Fox to come in to do a brief energizer. So here we go. What I would like you to do now is try to lift your ears up from your shoulders as far as possible. Stretch your neck out. Hold up those ears. Now bring your chin down towards your chest, like you're holding an orange between your chin and your chest, and feel that nice stretch right down the back of your neck, down into your back, and hold that there. Okay, great. Now bring that up. Now bring your right ear down to your right shoulder. Feel a nice big stretch down the side of your neck. Great. And the other side. And again. And again. And just roll your head around a few times. Stretch out that neck, stretch out that back. We've all been sitting for a number of hours. Big breath in and out. And again. And out. And one more time. Great. Now I need to make sure I can get back to me and I'm not stuck as a fox. Great. Thank you. So I hope you're feeling a little bit better because we've got a fantastic session this afternoon, but it is quite dense. And I'm going to introduce now the moderator for the next session on malaria. Prevention is better than cure. So our moderator for this session is Sashveen Singh. Sashveen is the Tropical Infectious Diseases Advisor for MSF France. She is a Master's in Public Health and Tropical Medicine, and a background in general practice pediatric and adult emergency medicine. Sashveen is co-lead of MSF's intersectional malaria vaccines group. And when not working on malaria, she is OCP's neglected tropical diseases advisor and on the OCP's epidemics team. Over to you, Sashveen.
Thanks so much, Joanna. And hello and welcome to everybody to the Paediatric Days 2022 session focusing on malaria. I'm very honoured to be asked to help moderate this session. So this session really aims to underline that prevention is better than a cure. So while acknowledging that prevention implementations can sometimes seem more challenging than providing well-known treatment options, over the course of this session, we're going to actually steer the discussion around the debate about these implementation challenges and really focus our attention on some quite efficient implementation strategies that will be able to consider the contextual and some of the seasonal variations that we see across MSF settings and different project locations. So we will provide some quite concrete field-based examples of vector control, intermittent preventive therapy in infants, or as it's known now as perennial malaria chemoprevention, and also SMC, which we've just heard about earlier in the day. So why do we need to be having this conversation today? The most recent WHO malaria report showed us from 2021 that there were actually 241 million cases of malaria that were recorded in 2020, and of which 627,000 were fatal. 95% of these cases and 96% of all deaths, sadly, were in the African region, and about 80% were actually in kids under 5. And four countries actually account for the majority of the deaths. And you can see on the slide here, Nigeria, DRC, Tanzania, and Mozambique. They're all places where MSF have a presence. And you can see from this graph that the trends in absolute numbers of malaria cases, but as well as deaths, have seemed to be plateauing over the last years. And despite current tools that we have for prevention, some high burden countries are actually even seeing an increase. 32 countries showed an increased case incidence, and 17 countries had an increase of 40% or more. That was just in 2020 when we compared to 2015 levels. The reasons behind this are a bit complex. So in sub-Saharan Africa, more and more people are living in malaria risk areas. Malaria funding has also been plateauing, sadly, and essential vector control interventions have been flattening in some places. So for many people living in risk areas, they also have trouble accessing emergency and primary health care. It's just not adequate. So we need to do something about this. Now, the use of long-lasting insecticide nets are already embedded in MSF interventions and has the potential to reduce malaria cases by 50% if they're properly distributed and used. But the distribution of nets just cannot happen in a vacuum. It has to be part of a broader package of malaria interventions. Strategies such as the implementation of IPTi, or SMC, IPTi can be massively impactful. And actually there's studies looking at IPTi, or intermittent preventive therapy in infants, using a drug called SP, or Fansidar, has shown to significantly reduce clinical malaria and the incidence of anemia in the first year of life, as well as hospital admissions with malaria infection and related to any cause. And recent studies have led to the WHO extending their guideline on IPTi recently to include children up to the age of 2 years. And this has triggered a name change. So this is now called PMC, or perennial malaria chemoprevention. And if we can widely adopt this and implement in recommended areas, it could prevent about 6 million cases of malaria and save tens of thousands of lives. Now, of course, there are new things on the horizon. Vaccines we'll hear about a bit later, which will be an important addition to our toolbox. But actually, our existing tools are not adequately implemented. So we have vector control interventions, we have preventive drugs, we have rapid tests and essential treatments. And in the near future, we will be adding vaccines. But right now, at the global level, malaria control is at a crossroads. So these tools, as I mentioned, are not adequately implemented. So despite gains since 2000 on some indicators, we know that bed nets are not adequately protecting because we've seen a decline in many places since 2017. We're also seeing less populations who are covered by the protection of indoor residual spraying. We know that not enough pregnant women are getting the Fanzida in the second and third trimester, and clearly this is having impacts on the neonates. And we're also seeing challenges with just the general planning and logistics and implementation of SMC. And if we add to this other threats, then it's really important that we take advantage of this additional impact. Additional focus on malaria in recent years. The WHO had a World Malaria Day this year, and I thought it was interesting to share with you that the theme this year was harness innovation and reduce the malaria disease burden and save lives. And this is a really timely reminder to us that we need to really strengthen all of our interventions. We need to be creative and we need to be proactive in order to tailor our interventions to the local needs. No single tool is going to be able to control malaria alone. Now, let's zoom in to MSF activities. So in MSF, in 2021, we treated 2,681,464 cases, which is enormous. And we've managed malaria campaigns for prevention in very diverse settings, such as Venezuela, Nigeria, Burundi, and Guinea. Sadly, in 2021, just two countries, the DRC and CAR, accounted for more than 50% of all cases of malaria that were treated by MSF. And these are the areas that have had very limited chemoprevention options in the past. But today we're going to hear from MSF teams who are doing some innovative work in those countries to address this. MSF has always been at the forefront of pushing delivery of malaria interventions to those in need. This ranged from implementing RDTs early on, making the switch to artesunate and ACTs, and also the piloting some of the biggest early pilots in SMC in West Africa just a decade ago. And as I mentioned previously, this renewed attention to malaria recently gives us the opportunity to engage more strongly on prevention. MSF have committed to harnessing this momentum in order to improve malaria implementation overall. During this session, we're going to hear from two external speakers. The first, Dr. Kike Sabat, who will be giving us an overview of malaria in children and sharing some challenges. And then Dr. Paul Sondo will be sharing his team's integrated approach of malaria and nutrition. And we'll also hear two very strong voices from the field, two MSF projects working hard on malaria prevention. Before we get started, I just wanted to remind you of the functionality of the platform. Most of you should have been in the session earlier, but just remember the chat, it's actually only for chat. So please don't put your questions in there, otherwise they won't make it to speakers for the end when we start doing questions. But if you do have specific questions, please use the Q&A. You'll see it as a tab on the right-hand side. Now, in order to prepare our minds, we are going to get thinking about malaria and kickstart this session with a short interactive activity. It's an online live poll. If you haven't done one of these already, you'll see on the right-hand side of your screen a tab called poll, which you can click now. Okay, so just remember, we've already gone through a few of these things, so I hope you guys were listening in the intro. The first question is, how many cases of malaria did MSF treat in 2021? Was it between 1 to 1.5 million, 1.5 to 2 million, 2 to 2.5 million, or 2.5 to 3 million? Okay, now hopefully you've got the next question up on your screens. What does the term IPTi stand for? It's now known as perennial malaria chemoprevention. Is it intermittent prophylactic treatment ideal? Identification preventive treatment infants? Intermittent preventive treatment infants? And the third question, how often can you wash a mosquito net? Is it each month? Is it any time I need to do it because it's dirty? Is it never? Okay, and for the final question, what malaria prevention activities have you seen implemented in project locations? Now, please note for this question, you can select all that apply. There is no wrong answer here. This is really just to have an understanding about the different types of interventions that you guys are seeing in your settings. Okay. So thanks so much for participating in that nice activity. Hope you enjoyed that one. It is my next task here is really to introduce our first speaker. So it is my great pleasure to introduce to you Dr. Kiki Basat. So Dr. Kiki is a medical doctor. He specialised in paediatrics from Barcelona in 2004 and also has qualifications in tropical medicine since 2004 from the University of Barcelona. He also has qualifications in clinical epidemiology from the London School of Tropical Medicine and Hygiene, which he completed in 2008. Later on, he completed a PhD in medical sciences in 2009 at the University of Barcelona with his thesis entitled Malaria in the Pediatric Wards of a Rural Mozambican Hospital and the Clinical Development of New Antimalarial Drugs. He's also a research professor for ICREA, which is the Catalan Institution for Research and Advanced Studies. He is the head of the malaria program at IS Global in Barcelona and also a practicing paediatrician with special interest in infectious disease epidemiology and public health. Dr. Basat has attempted to combine all his clinical work with biomedical research in those diseases that most affect the poor and vulnerable. His main area of interest has been the prevention and treatment of malaria in childhood, with a particular focus on understanding the clinical overlap of malaria and the other common paediatric conditions, and the use of biomarkers for both diagnosis and prognosis of etiological differentiation of febrile patients, and their risk stratification and prognostic evaluation. His research has also covered the new paradigm of malaria eradication, and he has a particular interest in evaluating the role in elimination strategies. So thank you, Kike. I hand over to you.
Thank you very much. I'll try to be very concise. I know I only have 15 minutes, so the idea is to have a quick overview on the malaria situation. First, a disclaimer, I don't have any conflict of interest, and my only potential conflict is that in 1999, the day I finished medical school, I had an unsuccessful interview with MSF Barcelona. So not that I didn't try to work with you guys. So let's start with malaria WHO, and I deliberately chose the picture of a pregnant woman and a young child, both of them receiving a blood transfusion. Anemia in malaria is the #1 cause of malaria deaths globally. And those two are clearly the two most vulnerable population groups. And I'm going to focus today on children. And where is malaria transmitted? So this is a figure showing where malaria was transmitted 120 years ago in the 1900s at the beginning. Essentially, malaria was a global disease transmitted everywhere. And this is the situation of malaria today, where transmission has been shrunk between the tropics, and it has been made by the action of man a tropical disease. But just to remind everybody that it's not inherently a tropical disease. It's the action of man that has transformed this disease into a tropical one. This is the distribution of the two main species, Falciparum and Vivax, essentially identical except for sub-Saharan Africa, where there is very little Vivax. Vivax requires a specific receptor in the membrane of the reticulocyte to invade the reticulocyte, and the majority of the African populations are Dophin negative of this receptor. Therefore, there is very little transmission of Vivax among native African populations, but there is a little bit in the Horn of Africa, and that has also some importance. Numbers, Sisha, you've mentioned already numbers, 241 million cases of malaria in 85 countries in 2020, vast majority in the WHO's African region. The number of Vivax cases has been revised and decreased and considered to be only about 2% of the global cases today. That's about 4.5 million. 627,000 deaths estimated to have occurred in 2020. Massive improvements since the early 2000s, but unfortunately a 12% increase since 2019. And I'll say a few words on that regarding the impact of COVID. 96% of all malaria deaths occurring in Africa. The countries that have been already mentioned, 4 countries accounting for more than 50% of all malaria deaths globally. And funny enough, you are treating about 1% of all malaria cases in the world. So you should be very, very proud as MSF. 77% of all malaria deaths occurring in children under the age of 5 in Africa. So essentially, malaria is a pediatric disease affecting mostly children in sub-Saharan Africa. And if we look at the overall causes of child mortality, all causes of under 5 deaths, malaria accounting for about 8% of the global deaths in children under the age of 5. If we were to look at this figure only for Africa, it would be around 20% of all African child deaths. And remember, this is the Africanization of the iceberg metaphor. We have quite good estimates on malaria morbidity and mortality, but as far as we know, we are only seeing the ears of the hippopotamus, or the tip of the iceberg, because many of those cases and many of those deaths are invisible to the health system, and they are occurring at the community level. And we need to remember this because we need to reach the community if we want to have any impact in our malaria control activities. And what about malaria control? So essentially, there are 3 main strategies. The first one is to reduce the contact between humans and vectors, essentially the mosquitoes that transmit malaria. The second one is vector control to kill those mosquitoes. And the third one is the use of drugs or other preventive strategies like vaccines. And remember that when we use drugs, we can use them to treat the cases already established or to prevent future cases using pharmaceutical preventive strategies. What about a few of the numbers? Because we have unprecedented success and progress in the last 20 years. 2.3 billion bed nets distributed in Africa in the last 15 years. The number of children under 5 sleeping under bed nets has dramatically improved from less than 2% in the year 2000 to around 50% today. We have an additional 2.6% of the African population protected through indoor residual spraying, nearly 250 million ACTs delivered in 2020, more than 2 billion since the year 2010. And the rapid diagnostic tests, which are the democratization of the diagnosis of malaria, which have significantly improved the way we actually identify malaria cases. 2.2 billion malaria RDTs distributed in the last decade. So amazing progress. Amazing innovation also. Just the fact that we have rapid diagnostic tests, even if they do have some caveats, but we didn't have them about a decade ago. So we should be very proud that we have managed to bring the diagnosis of malaria, democratize it, and bring it to the community level. We have much better bed nets today that can last up to 5 years and don't need to be replaced. We have new families of insecticides, although this is a field in which there is much need for innovation. We have a much better drug today for the treatment of severe malaria. Artesunate is clearly superior to quinine, and we have had massive improvements in the treatment of severe malaria thanks to a better and more fast-acting drug. And of course, we have a malaria vaccine that I will briefly speak about. Important to mention the chemoprevention strategies, particularly targeting vulnerable groups. We have intermittent preventive treatment in pregnancy, which is IPTp, which have what it was formerly known as intermittent preventive treatment in infancy, now called perennial malaria chemoprevention. And of course, we have SMC, seasonal chemoprevention for children under 5 years of age. The combination of these three strategies, even if the central one is not massively deployed yet, has importantly contributed to a decrease in the numbers of potential new malaria cases. So this is something that we need to have very much in mind. And even though coverage rates can be improved, this is a substantial innovation and change in regards to what happened less than 10 years ago. And we also have the mass drug administrations, and there are several ways of actually treating entire communities with MDA. We can use it for burden reduction in emergency settings, to reduce transmission of Plasmodium falciparum in very low to low or moderate to high transmission settings, or also specifically targeting PV transmission settings. So other strategies very well explain how to use them in the field, in everyday life. The new WHO guidelines specify very much the cases scenarios, and MSF follows those guidelines typically to deploy them. Just some examples of the numbers. SMC, about 33 million children were treated in 2020 with SMC. This is an improvement of 12 additional million children treated, thanks to the expansion of the program to some areas of Nigeria. As you know, Nigeria is the epicenter of malaria of the world. So anything that you implement in Nigeria is bound to have massive impact in terms of reducing malaria morbidity and malaria disease, and malaria death, sorry. Intermittent preventive treatment in pregnancy, we were having significant improvements during the last 10 years. Of course, the pandemic hit hard and we've had some reductions, but the message here is that we have important space for improvement, because only 1 out of every 3 women are actually receiving the minimum of 3 doses during their pregnancy, which is the minimum recommendation of IPTp. And let me just mention very briefly the new WHO guidelines, because this is important because the previous recommendations had 3 major pain points. First, it was perceived as a very lengthy process to change any recommendation. There were some inconsistent recommendations that were not necessarily applicable to all settings, and there was a suboptimal use of WHO's malaria guidance at the country level. And those new recommendations, who were published in 2022 and have recently been updated a few days ago, address those inefficiencies and enable faster, more flexible, data-driven decision-making for national malaria programs. And they're considered living guidelines, because they allow the rapid and clear dissemination of new evidence through an app platform. They are flexible, so they can be adapted to local contexts, because we do recognize that one size does not fit all countries, and therefore all countries need to be sovereign on their capacity to interpret and adapt those guidelines that fit them better. And this, of course, gives some country ownership for a sustainable fight. Let me give you a few words on the malaria vaccines. This is a very hot topic this year. Let me just show the clinical development of the RTSS malaria vaccine, the only vaccine that we have available today and authorized for its use in malaria endemic areas. But just for you to get an idea, this is the malaria clinical development plan of this vaccine. It took more than 30 years to actually have a product registered and recommended. Just compare it to the red little line in which during 6 months we had 4 COVID vaccines available to use in humans. So, and not because malaria is not a public health emergency, which was the rationale for running so fast with the COVID vaccines, but just because malaria is not affecting the entire world. And that has delayed unnecessarily the development of these vaccines. The first malaria vaccine implemented in real life was actually given on the 23rd of April 2019 in Malawi as part of this pilot project involving 3 countries, where 2.4 million doses were administered to nearly 830,000 children in Kenya, Malawi, and Ghana. And what we were able to see during this pilot project is that the administration of 4 doses of the RTSS malaria vaccine, including 1 after the first year of life, was feasible. It was equitable because it actually reached better than other malaria interventions like bed nets, the general population. And importantly, it had a massive impact because 1 life was saved for every 200 children vaccinated. There are not many interventions that can actually say that. 40% reduction in malaria episodes, substantial reduction in deadly severe malaria in routine use. So in 6th of October 2021, WHO endorsed its widespread use in sub-Saharan Africa. And the important and big news is that the field of malaria vaccine development is in good health. And we have new products, like, for example, the R21 vaccine that has shown 75% efficacy, not only in phase 2 trials, but more recently in phase 3 trials. We have excellent protection of the sporozoite-based vaccines in human volunteers. We have the prospect of an RNA-based malaria vaccine, mimicking what has been shown for COVID or for more recently for flu. We have excellent results of combining SMC with seasonal malaria vaccination, actually 70% increased protection over either intervention on its own. So malaria vaccine is not the magic bullet, but it dramatically improves the performance of other interventions if applied alongside. And we also have important developments in the field of monoclonal antibodies with very, very good results coming from field trials in volunteers first and also in the field in adults in Mali. But unfortunately, we have many perils ahead. We have funding gaps. It is calculated that we need $3 billion, that we would need up to $10 billion per year until the year 2030 to actually eliminate malaria, and we are only spending about a third of that. We have massive coverage gaps, some of which have been mentioned. Only half of the children are actually sleeping under a bed net, those who are at risk. We still have about 60 million malaria cases which go undiagnosed and untreated. And more importantly, we have important biological challenges. Insecticide resistance, very few new insecticides in the pipeline. Drug resistance, a particular problem in the Mekong region in Southeast Asia, but more recently identified also de novo appearing in places in Africa like Rwanda or Uganda. And importantly, RDT resistance, or that's how I call it for easiness, which is the fact that some RDTs, some parasites do not express the protein detected by the RDT and therefore are invisible to that RDT. And therefore that patient which is tested is not identified as having malaria and can die as a result of not being treated. There is an excellent malaria threats map published by WHO, which I recommend you to actually look at, that exemplifies all of this. And let me finish with COVID-19 and malaria. Let me also stress that the house was already on fire before the pandemic. And in 2017 and 2018 World Malaria Reports, this was very clearly identified. There was a stagnation of progress. Malaria situation was thought to be at crossroads. And if we were not to improve that situation, the risk was that we could go backwards again. And we know how dangerous it is to go backwards with malaria. There was also a fear with the pandemic that the distribution of bed nets, which occurs on a 3-annual basis every 3 years, and which had 2020 as one of the years of big distribution of nets in the continent, was going to be massively hit by the pandemic. And it was like that, this occurred. And there were many other mechanisms by which malaria could worsen the malaria situation, because mostly of the indirect effects of the pandemic and the lockdowns and the restrictions of movement and the air lockdowns, by which it was very difficult to have many of the measures reach the population at need. The worst case scenario, and this is my last slide, was there were a set of scenarios planned. And the worst case scenario said that we could have up to 769,000 malaria deaths in African children, so more than double the deaths that were occurring. Fortunately, the number has been less, but there has been a 12% increase of malaria deaths, and up to 2/3 of those additional deaths are estimated to have occurred because of service disruptions. So a big problem, but fortunately not as big as we thought, and we are catching up with the situation. And let me finish 5 seconds in advance. Thank you very much.
Great. Thank you so much, Kike, for giving us that walkthrough of what is quite a complex area. And as you can see from that presentation, there are so many things that interconnect. And, you know, we're going to get into more of that in the discussion later. I did forget to say that at the moment, we will be responding to your questions during the Q&A part as part of our malaria roundtable. So please do hold on to that, and we will present the results of the online poll then for you as well. Now, it's my great pleasure to introduce 2 video presentations that will run back to back next. These are 2 really great initiatives by our field projects. So first of all, we have a video from MSF Spain. It's the team in Batangafo in the Central African Republic. They're going to be presenting their experience of implementing IPTi. We all know what that is now, and which is now referred to as perennial malaria chemoprevention. It's a project that was implemented this year. And also then we'll hear from MSF Switzerland, the team in Angumu, Ituri province in the Democratic Republic of Congo. They will be presenting on a mass campaign that includes IRS and anti-malaria drugs in a community setting with a highly endemic transmission of malaria. So I'll hand over then.
Le traitement préventif intermittent chez les nouveau-nés, les nourrissons, les TPIN, est un traitement anti-palydique déjà approuvé par l'OMS qui est administré en une dose unique pendant la première année de vie du nourrisson, au même moment que la vaccination de routine. Il a été très démontré que le TPIN réduit globalement, n'est-ce pas, le paludisme clinique chez les nourrissons à 30%, tout en réduisant également les autres formes graves du paludisme. Il est capable aussi d'éliminer toute infection existante, mais aussi de prévenir toute nouvelle infection. Quand on administre de cette manière-là le TPIN, il est très bien utilisé par même les agents de santé communautaire. Il est très facile à manipuler et aussi ça minimise le temps de consultation et protège contre le paludisme pendant une période d'environ 35 jours. Il faut noter que la transmission du paludisme en République centrafricaine est très élevée, très élevée, surtout pendant la période pluvieuse. Et les structures sanitaires sont tellement sollicitées et 80% d'enfants sont vus au niveau de l'hôpital de Batangafo. Ils ont un paludisme grave. Vous allez comprendre que les services sont trop sollicités pendant la période pluvieuse où il y a une forte transmission du paludisme pour toute la population, y compris les enfants de moins de 5 ans. Pour lutter contre cette maladie mortelle, MSF a mis en œuvre depuis longtemps des stratégies de prévention de paludisme chez les nouveau-nés à base de la sulfadoxine pyrimétamine. Et aussi, il faut noter que d'autres stratégies ont déjà été mises en œuvre dans nos structures sanitaires, notamment à Batangafo. Et nous considérons que vraiment le TPIN comme un fort ajout à ce paquet de services. À part ce TPIN qu'on venait de dire, il y a aussi la distribution des moustiquaires, la décentralisation des traitements au niveau communautaire. Il y a aussi le diagnostic et la prise en charge du paludisme au niveau communautaire que nous mettons toujours en œuvre pendant la période de haute transmission, surtout pendant la période des pluies.
Ce type de programme, généralement, répond à plusieurs étapes
La première étape consiste d'abord à définir la zone dans laquelle le programme va se tenir et en l'occurrence ici, la zone pour ce genre de programme, c'est le service PEV qui est fonctionnel et qui parfois est appuyé par le partenaire MSF. Et pour ce qui est de la cible pour ce genre de programme, c'est généralement les enfants d'une année, enfin de moins d'une année. Mettre en œuvre ce programme-là doivent être formés. Alors pour pouvoir mieux tenir le programme, c'est-à-dire comment organiser, quelles sont les informations qu'ils doivent en fait recueillir pour à ce que le programme soit effectif. Donc ils doivent être, comment dire, formés pour renseigner les supports d'évaluation et aussi de suivi du programme. Pour conclure, je tiens juste à rappeler que c'est un programme qui vise beaucoup plus le côté préventif du paludisme. Mais il faudrait aussi noter que c'est un travail un peu laborieux parce que les mamans ont toujours tendance en fait à prendre en mal un peu les choses et s'ils voient que peut-être leurs enfants réagissent aux médicaments, ils pensent que le programme n'est pas efficace, alors que c'est juste question en fait de comprendre que tout médicament qui sont pris par les enfants, parfois ils peuvent réagir par des effets secondaires. Et donc la leçon à tirer, c'est beaucoup plus de mettre l'accent sur la sensibilisation, encore la sensibilisation.
MSF est présent dans la zone de santé d'Angoumou depuis 2019 et MSF prend en charge les populations autochtones et populations déplacées issues des atrocités et de l'insécurité des groupes armés présents. Nos principales activités sont la prise en charge des pathologies dans les centres de santé et également à l'hôpital de référence de Angoumou. La malaria est hautement endémique ici et s'étend sur toute l'année, ce qui constitue d'ailleurs la principale cause de consultation dans les centres de santé et à l'hôpital de référence. La prévention reposait uniquement sur la distribution de moustiquaires coordonnée par le ministère de la Santé et MSF. Et aujourd'hui, je peux dire depuis 2020-2021, nous avons essayé d'étendre nos activités de prévention avec la distribution massive de médicaments et de la pulvérisation intradomiciliaire qui connaît un grand succès en ce moment, qui nous a permis d'étendre nos activités au niveau de 10 aires de santé.
Les zones d'intervention ciblées pour la MDA sont les aires de santé proches du lac, sont les aires de santé qui hébergent des sites de déplacés. La zone est endémique parce qu'il y a eu d'abord la montée des eaux du lac, ce qui a favorisé les endroits stagnaques, qui est un endroit vraiment propice pour la multiplication des moustiques.
Et par rapport à cette activité de pulvérisation interdomiciliaire, nous avions collaboré avec le ministère de la Santé publique à travers le comité de santé et la cellule d'activité communautaire au niveau des villages. Le contrôle vectoriel vise à interrompre ou à perturber la transmission du paludisme et en limitant l'interaction entre les humains et les moustiques.
Oui, il existe plusieurs étapes pour arriver à réaliser cette activité. D'abord, il faut faire l'évaluation du nombre de maisons à pulvériser. Ça, on a fait appel à notre DIS à travers l'acquisition d'une image satellite, ce qui nous a permis d'avoir une idée sur le nombre de maisons pulvérisées et le nombre des insecticides dont on aura besoin pour faire cette activité. Ensuite, on a développé une application qui nous permet de faire le suivi de cette activité à distance. Nous avons effectivement collaboré avec le ministère de la Santé, ce qui nous a permis d'avoir 120 relais communautaires mis à notre disposition par le ministère de la Santé. Ils ont été formés comme des agents pulvérisateurs, c'est eux qui font les activités sur le terrain concrètement. Nous avons construit deux bases arrière qui comportent de vestiaires, de douches et autres, ce qui a permis de rassembler les équipes parce que les agents, une fois partis sur le terrain, ils viennent s'échanger pour... Ils doivent aussi se laver. C'est pourquoi nous avons conçu cette base arrière.
Le programme de promotion de la santé est indispensable
car il nous permet d'assurer la mobilisation de la population pour atteindre un minimum de 80% des maisons à pulvériser. Et pour cela, il faut que les gens nous laissent entrer dans leur maison. Et l'HP passe pour informer la population par rapport à quand aura l'activité et pourquoi cette activité sera faite. Deux fois, il y a des refus à cause de mécontentement ou odeur du produit, mais quand nous arrivons à négocier avec eux, les gens acceptent facilement.
Le travail des entomologues ici consiste à étudier des moustiques pour raison de suivi et de contrôle de la qualité des pulvérisations. La capture des moustiques, en fait, dans la communauté, nous déployons des pièges dans le but de surveiller la densité anophélienne et de voir s'il y a des possibles changements dans les espèces de moustiques qu'on a dans la zone. Grâce à nos différents tests, nous nous assurons que le moustique ne développe pas une résistance à l'insecticide, ce qui est aujourd'hui un problème aussi grave que la résistance aux antibiotiques.
Alors en fait, le contrôle vectoriel est essentiellement grâce aux moustiquaires imprégnés et à la pulvérisation intradomiciliaire aussi. Et la raison principale de la réduction des cas observés mondialement depuis le début des années 2000 pour la malaria. Par contre, chaque contexte est différent et nécessite une réponse adaptée. Que ce soit au niveau de la résistance aux insecticides, que ce soit dû aux habitudes humaines ou bien au comportement des moustiques. Donc chez MSF, c'est une décision qui est opérationnelle et qui implique tous les départements. Ça peut avoir un impact particulièrement fort et marqué sur la transmission. Et donc l'intérêt est de pouvoir réduire le fardeau de la malaria pour les populations. D'un point de vue pratique, ça veut aussi dire que les autorités nationales seront donc plus à même et pourront prendre en charge plus facilement leurs responsabilités, notamment de soins par rapport aux populations.
So thank you so much. Big thanks to the field, both fields, for really excellent quality presentations. And I think it was really interesting, particularly in the IRS presentation, where they really highlighted the importance of community engagement. We haven't discussed that so far in this session, but I want you to keep that in mind, maybe for later. It's my very great pleasure next to introduce our next speaker. He will be presenting a very nice video to explain some of the really interesting work that he's been involved in. So Dr. Paul Sondo, he's a medical parasitologist with a focus on malaria research. Following his PhD, he undertook some career development programs, including the esteemed EDCTP TDR, Clinical Research and Development Fellowship, and also the EDCTP Career Development Fellowship. So for those that don't know, the EDCTP is the European and Developing Countries Clinical Trials Partnership, and the TDR is a WHO-affiliated special program for research and training in tropical diseases. Over the last 5 years, Paul has been working on projects such as assessing the efficacy of antimalarial drugs and also investigating the genetic diversity of P. falciparum and its mechanism of resistance to various drugs. More recently, his work has focused on SMC through the implementation of two quite big projects, which included SMC Newt and SMC RST. And he's also been awarded the Institut Mérieux Young Investigator Awards in 2018. A very warm welcome to Dr. Sondo.
Bonjour, je suis Paul Sondo de l'Institut de recherche en sciences de la santé.
Good morning. I work at the Health Research Center in Burkina Faso. I will be presenting the research of the National Plan Against Malaria and the Ministry of Health Nutrition Department study, which focuses on the evaluation of a combined strategy of SMC with plumpidose and vitamin A zinc supplementation for the prevention of malaria in Burkina Faso. To double, I'd like to remind you that malaria is a major public health issue. Prevention of malaria is a key component of the disease control strategies, and the means to prevent it are mainly focusing on long-acting impregnated mosquito nets, IRS, preventive treatment in pregnant women, and SMC, which is an intervention which aims at reducing the prevalence of malaria in children aged 3 to 59 months. This map shows the distribution of seasonal malaria in Africa. Most of the cases are found during the rainy season. In Burkina Faso, it's between July and November. So Burkina is an ideal setting to introduce SMC. This type of prevention measure involves a combination therapy given to children aged 3 to 59 months every month for 4 months, and or up to 5 months, depending on the rain levels. And between June, August, September, and October, we have SMS implemented. It helps to reduce the incidence of malaria by some 75%. But in spite of this strategy implemented in Burkina Faso since 2014, we still have a high burden due to malaria in children under 5. So we wondered whether there were some factors that had a negative impact on this intervention. And when you consider malnutrition, as you know, it is a major cause of child morbidity and mortality, because it weakens the immune systems and results in more severe forms of malaria in the general population, and also a decrease the efficacy of the anti-malarial treatment. Even more than that, all the micronutrients deficiencies, when they are treated, are known to reduce the morbidity and mortality. So based on this, we have come up with an assumption which would be combining SMC plus micronutrient to help better reduce the burden of malaria and malnutrition in these children. And for that purpose, we have set as a primary objective evaluating whether SMC plus vitamin A plus zinc, that is, and also plus plankton and vitamin A would be more efficient to reduce the incidence of malaria while improving the health status of children, as opposed to the standard SMC. The secondary objective is to assess the impact of this strategy aimed at reducing the impact on children. Our methodology is the following. We have 3 arms. It's a randomized study which was carried out between July 2019 and June 2020 in the Nanoro Health District. In the first arm, Plumpy-dose was combined with SMC. The second arm is the control arm with no supplementation. And the third arm is the arm where zinc was added. There was a 12-month follow-up, 6 months of active monitoring, and 6 months of passive monitoring. And over 4 months, the Plumpy-dose was given. Plumpy-dose is a ready-to-use therapeutic food, which can be directly used at home without requiring any specific preparation. 1 pouch a day per child was given for 4 months during the SMC. And for zinc, each child was given 1 zinc tablet containing 10 milligrams of zinc 6 days per week for 4 months. That is the whole SMC period. So these are the results and our findings. In total, 1,059 children had been randomized with 3 arms, 353 children per arm. At the end of the follow-up period, we have had more than 97% of children in the Pompidou's arm, 95% of children in the control arm, and 96% of children in the third arm, that is zinc supplementation, which is quite an acceptable follow-up rate, which shows that the monitoring system did work rather well. Most of the children were sleeping under long-lasting and long-acting impregnated mosquito nets. That's 91% of them, which when the SMC started, the positive rate of 2 RDTs was 22%, and microscope studies showed 10% positive rate. Malnutrition prevalence was very high in these children at the beginning of the SMC. Stunting was also high, and there was also a low weight that is reflecting acute malnutrition. And the prevalence of malaria is already very high before starting the SMC campaign, suggesting a need for an early starting of SMC in the area. And also, when you consider the prevalence of malnutrition, most of children were malnourished during this period. So there is a need to promote a synergy type of intervention to control both malaria and malnutrition during this season in this area of sub-Saharan Africa. The impact of this intervention is shown here. We can see the impact of the supplement given on the incidence of morbidity for all causes and the reduction of severe malaria. The green line is the control, the red one is a zinc group, and the blue line is that of children who were given the Pompidou's. The first graph shows the morbidity for all causes throughout the follow-up period. Morbidity went down in those children who were given these nutrition complement. The graph in the middle shows the simple form of malaria incidence throughout the SMC period. And here again, those children who were given the supplement had fewer cases than in the control arm. Now, when it comes to severe malaria, those children who were given Pompidou's in addition to the SMC have shown a significant reduction of severe malaria versus those who were given zinc or those of the control arm, control group. Now, we may conclude from these results that throughout the peak of the malaria season, many children with SMC treatment are also having malnutrition. Now, the feasibility of a strategy combining SMC plus micronutrient supplementation in sub-Saharan Africa is possible. This micronutrient would help further the impact of SMC to reduce further the morbidity related to malaria while improving the nutritional status of children. And this was even better when using our UTFs such as Plumpy-Dose. I would like to thank all those who've helped us and worked in this study. I'd like to thank our partner, IDCTP, which has helped us to fund 100% of this study with the Caritative Fellowship Program. I also would like to thank the National Program to Control Malaria and the Nutrition Department of the Ministry of Health, and also NutriSet for providing the Plumpy-Dose for this study. And I would like to thank the local community and all those who've taken part in the study. And I'd like to thank the staff of this health area, and a great thank to Nanoro and the community health worker of Sao and Zoid Gomde for all their support. Thank you also to MSF for having given me the opportunity to present the result of this study along with the scientific community. Thank you to all of you for your attention. Thank you very much.
Hi, and thank you so much, Dr. Sondo, for presenting that very interesting research. I hope that we get a chance very shortly to have a discussion on that. You were able to introduce some of the challenges that we really see in field settings. Now, the next part of this session is going to be very interesting. I'm quite excited about this. We're going to a round table. So apart from Drs. Paul Sondo and Kike Bassa, who we already introduced, we have also invited Mitchell, Letizia, and Arnaud to join the roundtable discussion today. So Mitchell Sangma is a medical doctor from India with a postgraduate degree in international public health from the University of Queensland in Australia. He has worked with MSF since 2011. As a public health specialist, he has been involved in multifaceted health programs in complex humanitarian situations, everywhere from Uganda, Uzbekistan, Zimbabwe, Syria, Turkey, Jordan, South Sudan, Ethiopia, Nigeria, Bangladesh, and Myanmar. Yeah, it's quite impressive. And currently, as MSF's OCBA Health Advisor, he's based in Nairobi. Mitchell has been providing direct medical support to the complex field operations in South Sudan, Sudan, Somalia, and Ethiopia. Next, we also have Letizia Di Stefano. Thanks, Letty. She's a medical doctor and infectious diseases specialist, and she has started working for MSF all the way back in 2009. She's held many different roles also in MSF, firstly in operations as a field doctor and a medical coordinator in countries such as the Central African Republic, Guinea, and Pakistan, and also as deputy operations coordinator, focusing on Nigeria, Mali, and Bangladesh, amongst others. She also previously worked in TB/HIV as an advisor and implementer in the OCBA medical department, and now is a referent for malaria and neglected tropical diseases in the Brussels headquarters for MSF. and very much focusing on malaria and neglected tropical diseases these recent times. And finally, last but not least, we have Arnaud Desjardins. We saw a little cameo in one of those videos of him there. You might recognize him. He's a former nurse with a background in emergency room and tropical diseases. Arnaud joined MSF OCG in 2016, MSF Swiss, and after a few missions, first as a nursing activity manager and then once as a project medical referent, he decided to return to his true passion, which is biology. After a master's at the Liverpool School of Tropical Medicine, where he dedicated time to biology, epidemiology, and the control of parasites and vectors, Arnaud then went to a field mission for vector control in Honduras in 2021 with MSF to prevent dengue fever. And he now works as a flying vector control for OCG, MSF Swiss, in order to really support the field in the practical implementations of vector control activities, like we saw in the Angumu video. So thanks so much and for joining, guys. I think we're going to have some really interesting discussions. I thought I'd open up with a first question. It's a bit more broad, but just considering we've been talking about a lot of different projects and settings, I wanted to pitch this one mostly to Mitch and Letizia at first to have that MSF input. What malaria interventions do you think should exist in all our projects?
Perhaps I can start. Well, first, warm greetings from Nairobi. And I think I must say that I was very inspired by seeing the videos from the field. But anyway, coming back to the discussion points, well, I think as highlighted in the presentations, that there is no one size fits all. I think when we talk about the projects, about all the projects are different, even in the same country, even in the same districts. So I think that's very important, right? While looking at the intervention strategy, that we need to consider the important factors, especially in identifying the population at risk, identifying the most vulnerable group, and also acknowledging the presence of other actors, and including the presence of factor control programs. And I think the most important point is also the security. Like in many of the MSF projects, we work in conflict-affected areas. So we also have to see the feasibility of what type of malaria interventions programs we can implement in certain settings. And of course, the context itself, whether it's a closed setting like IDP refugee camps or it's an open catchment populations. But when it comes to the very basic, right, what we expect from the malaria interventions, I think, what we expect and what we should have in all the projects in MSF projects in malaria endemic area, I think number one is the access to the rapid diagnostic tests and essential drugs, availability of the simple fight protocols. And of course, it's a bonus when you have the access to the long-lasting insecticides, long-lasting mosquito net. And it's a double bonus, I would say, when you already have the community program in place. Now we are acknowledging the importance of community programs. And I think in the recent years, we have shown that, how it has been able to decentralize the programs at the community level. It was a long discussion and debate, I remember, in my younger days when we started rolling out the community programs, talking about how we can do that, how will we monitor the quality. But over the times, I believe that we have learned that it is possible. So the presence in the community, I believe, is a very important component. And also what you mentioned, Safshin, about the community engagement to get the feedback. So I think it's a very important aspect. So coming back to your core question, I think it's the drugs and it's the rapid diagnostic tools, which are the two core components, I would say, for any malaria interventions. But then the intervention strategy, it depends upon the project ambitions, about the external factors, and of course, the target populations. But often when there's a disparity, even within the same MSF project, when you talk about the different intervention, and some of them, of course, these are planning dependent or decision-making dependent.
Great, thanks so much, Mitch. Letizia, from your side, as a malaria referent, have you got things to add?
Yes, I fully agree with Mitch. And I think practically what we can do is indeed two very simple things. Mitch mentioned the distribution of mosquito nets, I think during routine activities. And indeed, we have fantastic opportunities. For example, when we do discharge a child after hospitalization, or when we do perform antenatal care consultation. So this is very easy and feasible activities, but indeed we are providing an important preventative tool. And then, of course, the case management, I think, is the key, one among the key activities in all malaria strategy. And performing almost everywhere, I would say, medical consultation, I think, is quite a must to perform early diagnosis and treatment. And above all, as mentioned, also at the low level of care. So primary health care, but if we can indeed expand and scale up at community level, this would be an added great value.
Great, thanks so much. And I think this kind of follows on with some of the things we've already been discussing, but I wanted to throw this question out to Arnaud and Dr. Bassat. So if we really want to start thinking about how to implement some prevention activities in our projects, where do you guys normally start? What are the things that, you know, we should be assessing and considering before starting to make a strategy for our projects?
Arnaud, you want to go?
Yeah, okay, why not? I can start. Maybe one of the first thing we can do is already to check with other partners what is already planned. And because it's really, really usual that other NGO, other partner like UNHCR or that kind of people already have some project plan. And so one of the first things to do maybe could just assess what is already done or what is scheduled to be done in the next few days, months, and to create a collaboration between us and the other partner. That would be often one of the first things to do before to start to implement something or to spend a lot of resources on a project. I don't know if Kike want to add something.
I would agree with this, and I would also use opportunities which already exist and have good coverage. No, expanded program of immunization as a way to access children under the age of 1, antenatal consultations as a way of reaching pregnant women. And particularly for MSF, which has a direct contact with hospitalizations in general, post-discharge, it's an excellent opportunity to also reach, as Leticia mentioned, for the distribution of bed nets, but also there is a recent wave of research looking at post-discharge prophylaxis for children with anemia, non-traumatic, non-hemorrhagic anemia, because it's been shown that if you give an anti-malarial drug at the moment of discharge, you even if that person was not known to have malaria, you do actually decrease the subsequent risk of malaria and the outcomes in general. So using existing opportunities for direct contact with the population, because at the end it's always an access, or most of the time it's an access problem. When you are already guaranteeing that you will have a decent coverage, both from vaccination and from antenatal consultations, or when you know that the child is in contact with you because you have had that child hospitalized, those are opportunities that you cannot miss.
Yeah, great. Thanks so much, guys. And I think you've brought up some really key points there. This actually does lead us on to another question I was really keen to ask you. And I think I'm going to throw this one at Dr. Sondo and Kike, because it relates a lot to the kind of work that you guys do. If we want to actually combine efforts more efficiently, I mean, Kike just mentioned we have to use these existing opportunities, this opportunistic, administration of preventive activities that are integrated into something else. How can we actually do that in, for example, mass activities, or it can be quite challenging. And I think we need to think about how we can combine efforts more efficiently to tackle not only malaria, but things like malnutrition, measles in the community.
Prof. Sondo, s'il vous plaît.
Yes. Okay, thank you very much. This is an interesting question, how we can efficiently combine several interventions. That is, to me, the first thing is about accepting to work together, to work together. No one has a leadership in fighting any specific disease, and we should work together in order to efficiently implement joint intervention. And this starts by a political commitment, because in most of our Ministry of Health, we have a department for them. In Burkina Faso, we have the Direction of Nutrition, who intend to work separately from the National Malaria Control Program. And in such context, it's difficult to efficiently plan a joint intervention. So at the political level, we should set up an efficient system that allow the different directions to work together. And in such context, we can reach the groups in the field and better implement a joint intervention in the field. That is what I think we should start with.
And I would add that again, opportunities for synergy. The visits during the first year of life in infants for vaccination are the perfect example. We built IPTi, or what was formerly known as IPTi, around the visits for vaccination. That's why the first dose of SP was given at month 2, the second at month 3, and the third coinciding with the measles vaccine at month 9. Because the opportunities existed at that time, not because there was a predetermined plan to space intervention 1 and 2 with 1 month and the other one 7 months later. No, in EPI you also distribute vitamin A for the prevention of the consequences of measles. So there are plenty of opportunities for synergy, and provided there is good safety of the mixing of interventions, always providing there's good safety, and of course you need research to show that. There often is synergies occurring between the two interventions. The recent example of adding the malaria RTSS vaccine with SMC shows that on their own, neither of the interventions, either RTSS or SMC on their own, is better than the combination. And it's not additive better; it's a multiplicative better. So there's always a need to look for those opportunities. And beyond that, there's also a need to assess what can be the added benefit of mixing interventions. For example, I will briefly mention ivermectin distribution in MDA for other neglected tropical diseases. We now know that ivermectin is effective at killing mosquitoes that bite somebody that has taken ivermectin. So could you have an additional added benefit in terms of interruption of malaria transmission when you are treating your entire population with ivermectin, not at the individual level, at the population level? So these kind of synergies and peripheral or beneficial additional effects need to be explored, because we will always win when we join forces, as Dr. Sondo was saying.
Yeah, and I'm so glad that you and Paul have brought these topics up, because particularly around this, integrating various interventions and finding the opportunities. And some of these things are so, in a way easy to do. We already have this child contact. We can quite easily give vitamin A. It's very compatible. And albendazole is another example. And it was really nice to have that example of the ivermectin and the transmission blocking. I think the next question, we should move to a bit more to talk about some of the challenges of implementing prevention activities in different settings. I'd like to pitch this one probably at Mitch and Arnaud to give us a few different perspectives on, if we're thinking about certain challenges of preventive activities, how different are the challenges when we're thinking about an emergency context, an IDP camp setting? Yeah, can you share a few reflections there for the team?
Sure. If I may, Arnaud. Well, I think it's a very good question when you talk about the barriers, and I think it's also the time for self-reflections. But here I must say that, of course, when we talk about the barriers, that there could be a different type of barriers. But perhaps for the sake of this discussion, I'd like to focus more on the internal barriers. Like as I was mentioning, like there are external barriers like related to the access because of the security, because of the distance, or there could be a barrier because of the cultural barriers or the uptake barriers for which we may need more anthropological approach, or we may need much more community engagement strategy. But these, of course, the solutions are very much context specific depending on the project locations. But when we talk about the internal barriers, of course, I think it's a good question. And but perhaps before I touch a little bit more on that, I think we can talk more about some of the good practices that we should also acknowledge. That yes, when we are looking at our project locations, like in most of the malaria endemic areas, I think there are certain levels of protections, activities or programs that we have already integrated, such as like what has been mentioned, like simple distribution of long-lasting insecticides for the pregnant woman coming to our clinic, or even integrating a very basic health education and health promotion messages, like especially with focus on personal protection measures and environmental hygiene. And I must say, like maybe just to give an example, like how I like talking about the mosquito net, like in my earlier days when I joined MSF as a young clinician, it's not that I'm old now, but in the field, I often faced the feedback, like from the field about the uptake of mosquito net, like how it was being misused, how they would use it for fishing or for any other reasons. But then 10 years down the line, now if I visit the project, I've seen a good acceptance from the community. And I think this has gone through like years of health education, engagement, promotions. And of course, it's a bit annoying to be bitten by a mosquito. So once you have that habit, you could easily follow the habits. So I believe there are already some good practices which are already happening. Also talking about the chemoprophylaxis, like how we're integrating into our ANC program, how into the pediatric program in some of the project. So I think we should also acknowledge that. But when you talk about the large-scale community program like SMC, like mass drug administrations, I think this is where we often face a bit of challenge in decision making. First, number one, I think it's also to understand the objective of prevention program. Sometimes the objective could be just to show it as a pilot because it's a new program in that country. So we want to do it as a pilot and use the result to show that it works, and then use that for advocacy and for networking with the bigger donors. Just to give an example of South Sudan, we have done that. Yes, in 2020, we were the first one to pilot this SMC program in 10 villages, or 12 villages, targeting around 10,000 children. We got a very good result, which shows that, yes, it decreases the episodes of malaria, decreases the severe malaria. But then it was just a one-time episode in 1 year, and then it stopped. So there was no continuity. So I mean, the real purpose here was to show that, yes, it works. Then, of course, when you talk about the context like South Sudan, where government is often already challenged with compelling priorities in terms of funding. So they cannot we cannot find the partners to continue with that. But when we talk about the large-scale community program for the purpose of prevention itself, like in the community, that sometimes, yes, it needs commitment, it needs motivations, it needs resources, dedicated resources, and of course, it needs budget. And like with the day-to-day work and activities in the project, sometimes we can be a bit myopic, not thinking outside of the box, especially during the planning phase. We tend to focus on the immediate gains or immediate program interventions. And sometimes we are a bit limited that some of the long-term prevention program, it also needs multi-year planning. But sometimes the scope of our MSF planning cycle, sometimes it limits that we just look at the 1 year planning. So I think those are some of the factors. And of course, there's also the high turnover of the managerial positions who make the decisions, and which can also have an influence on the current ambitions and looking at the preventions. So I believe that there are lots of reasons, like even within the organizations, that yes, but I hope that such events like this Pediatric Day will continue to inspire us to think outside of the box, especially during the planning phase. So I believe that engagement, continued discussions are important, and of course, but yes, in the end, it's all comes back to the project or the mission specific decisions.
Yeah, great. And Arno, have you got some reflections on the sort of closed and emergency setting, some of these challenges and how to manage those?
I will continue also on what Mitch was telling us. I fully agree because you cover pretty well the challenge we can face when we want to implement some activities. But most of the time, one of the main challenges is just also that people don't know what are the tools available to prevent malaria in the different contexts or the different setting where we are doing our intervention. And that is also something that will prevent to implement something efficient. Main challenge, as you say also, and I really want to insist on that, is the planification. When you want to do your intervention and the time you need to prepare the intervention. You need the supply, you need the human resources, you need to conceive a whole project, and that can be really, really challenging. So that is also one of the main challenge. And the last one I wanted to highlight also is most of the time is what exactly you want to achieve. What is your context? And so what do you want to do? Do you want to just protect your population? You just want to do some prevention? You want to control, to decrease the transmission, or you want to eventually eradicate the transmission, let's say, at least locally? So everything, it's something you have to consider when you want to implement that kind of prevention program. And it's not always easy, but we are here for that and to support people on that. So according of what you want to do will depend on the context. So I will go back to the emergency setting. Finally, each context is very different. So yes, unstable context or emergency context, you can do a lot of things. What you have to decide about the scale of the context. It's possible to do some remote prevention program, but it's quite complicated. So you have to prepare it even better than other program. And in refugee camp, you have a lot of to do also. You have to ensure, as you said before, we have basic requirements. Every patient have to sleep on and to be protected by a mosquito net. You have to ensure that the mosquito net distribution, even if it's done by other partner, it's properly done, because as Mitch said, you can have some misuse, but finally not that much. But the problem is the retention at the end of the distribution can be very different of the initial target. So all these programs have to be really considered and to be, let's say, carefully prepared. And but you can do a lot of things, whatever it's emergency, chronic program, or unstable. There is a lot to do, and we can do very efficient intervention.
Okay, great. Thanks so much. Yeah. I'd like to ask you guys now, because you were talking about how there's so many things that we can do, and you've given it quite a number of different examples of different things that we can kind of consider to implement. But I wanted to see with Dr. Kike and Dr. Paul Sondo, can you maybe share with us some of the most interesting or innovative combinations of interventions that you've seen in projects, tailored to a specific place, and then how did they go?
Yes, maybe if I may start this time, I can think of practical examples of interventions that people don't think are important and are critical. For example, during the Ebola outbreak in 2014, the big epidemic in the 3 countries, the mass drug administration of anti-malarial drugs saved many more lives than the actual prevention measures of Ebola. Or in other words, malaria was causing many more deaths than Ebola itself, even though all the focus was put on Ebola. Similarly, mass drug administration in northern Mozambique during the big floods and the typhoons that occurred a couple of years ago was an essential maneuver to actually decrease malaria morbidity in the north of the country in a context of humanitarian or climatic crisis. No, so sometimes interventions that are not meant to be and are decided ad hoc because of the specific problematic of that moment end up saving many lives and end up having a massive impact. And I could think of this as a good example. And perhaps as a second example of combination of interventions, this is more in the innovation pipeline, not yet a formal recommendation, but for example, the addition of azithromycin to IPTi, to intermittent preventive treatment in the youngest, knowing the results of the Mordor trial in which azithromycin was shown to decrease child mortality when administered massively to a given population, that could be a big addition, no? And act synergistically to the impact that already IPTi causes, no? So thinking about interventions of things, even though sometimes they come from different fields, no? Azithromycin was an intervention given for trachoma initially, then showed this decrease in child mortality when administered as MDA to children. And IPTi is a malaria-specific intervention, but combining the two things together, why not? And this, of course, is currently being tested. It needs to be tested, again, as I said before, to guarantee the safety and to measure the potential additional impact before it becomes a recommendation. But these are the kind of synergies that we are so desperate in need for, and that could make a big change.
Yes, to add something to what Professor Kike has just said is the perfect synergetic intervention between malnutrition and malaria. And if in Burkina Faso, for example, vitamin A supplementation is also adopted as a national-wide intervention and during SMC round, there is a screening for malnutrition, and it's a perfect marriage. The intervention against malnutrition and malaria is a perfect, I can call it marriage, because it's applied to the same population, specifically children under 5 years. The second example of a synergetic intervention is that I would also like to mention is the combination of IPT during the antenatal care, and it's worked perfectly for as well as for child and for mother's health, and it also works very well. And in this line, we are implementing now a project who is using SMC intervention to improve antenatal care, or called an integration project. We will try doing SMC to see whether we can increase and sensitize pregnant women in the families in order to increase adherence to attendance to health facilities for antenatal care.
Thanks so much. And I really like this concept of sort of, thinking about interventions from even different disciplines. And I think that's a really important take-home point. I wanted to move on to something, maybe this is, I'd be really interested to hear about what Arnaud's pitch is on this one, and probably also Mitch from an operations point of view. We're seeing some current impacts of climate change on many diseases, including on malaria and the burden. For example, with more extreme weather events, there's more flooding, more displacement of populations, potentially to higher transmission settings. What things should our teams be thinking about when dealing with these types of issues? And are there particular measures of prevention or adaptation that you think we need to have like a climate hat on when analysing these types of contexts?
Arnaud, you want to go first this time?
After you, please.
Okay. All right. Yes, unfortunately, I think we're already seeing the first-hand impact of the extreme climate change in many of our mission locations, especially in the Horn of Africa. Like the current drought that we are seeing now, which has been described, like current drought in Somalia, part of Ethiopia, in Kenya, which has been described as the worst in the last 70 years, with the consecutive failure of the 4 rainy seasons. While on the other contexts, such as in South Sudan, we are seeing the extreme of floods, with the extended rainy seasons, right, in the last 2 or 3 years, and now, which has been causing a massive displacement, especially during the rainy season. So I think we're already seeing the impact of the climate change has, I think, attributed to the extreme climate changes. And of course, I think with these changes, I think it's very important that we start monitoring the epi trend, looking at our the malaria burden or the other disease burden, how it changes with what we are seeing now in the recent years. I think this monitoring, analysis, and reflections is very important to see whether what impact it has, especially in terms of the caseload. For instance, in South Sudan, especially with the heavy rain, we are seeing the flushing of the breeding places. So in the beginning of the heavy rain, we are seeing a reduction in the malaria caseload. But then again, the malaria season is extended. So then again, when you look at the total number of malaria, it's still it's more higher than compared to the last year. And where the context like in South Sudan, we are seeing the reduction in the malaria cases, but we also see now the starting of the other outbreaks like dengue, chikungunya, and other diseases. So I think we need to have that. I think the understanding part and how it is impacting, especially with the disease burden, with the current changes. And I would also like to add that the entomological surveillance would also be very important if we have that capacity, especially to understand the change in the transmission rate. So I believe having the understanding of the context or understanding of the change in the recent event, it's very important. Perhaps just to give an example, like in South Sudan, we have been expecting the flood every year. So, and of course that was creating a difficulty for the patients from the community to come to MSF hospital. So now we started decentralizing more and more, like what we in MSF Spain, we call it decentralization model of care, or I think it's an ICCM strategy that we started decentralizing, started pre-positioning more malaria drugs at the community level, especially during the malaria season. And we also know that especially for the very severe cases, we still need to get to the hospital. The access has been very difficult. So now for next year, we started planning to put on some local canoe, the local boat, give to the community itself, so that they can arrange and they can coordinate and they can come with the support of MSF donated local boat to the hospital. So I think these are some of the measures, just to give an example of how we need to take into considerations the recent changes that we are seeing, and how we can put certain measures, simple measures in most of the cases, but that can make a difference. And just also to highlight, talking about the impact of climate change, and of course the impact on the displacement, the massive displacement, like what we are seeing in Somalia. It's an emergency situation, and every emergency situation is very challenging. Like Arnaud has already mentioned a bit about difficulty of getting the supplies in, the HR gaps, especially in the new context where we don't have the team there. Then it's or when there is no scope of hiring the local professional staff, and yes, flying in the international staff, it often takes time, or even the hiring the local recruitment at the project or at the emergency site, it's also very difficult. And also during the emergency, there's compelling priorities, there's a very need to set up the very basic food, shelter, water, safe drinking water, sanitations. So there are compelling priorities, and often when we look at the prevention program, it often takes a little bit of backstage, because the focus is on life-saving emergency interventions. But here, I just like to mention that, yes, in some of the projects, we have been trying to integrate already, within the existing life-saving interventions, that some component of preventive programs, like distributions of a mosquito net. I think it's a good example where we're already integrating that into our existing programs. So, I mean, just to bottom line, I think it's when we talk about the impact of climate change, it's there. So, but we need to adapt, we need to change. But for that, we need to have an overview of what's happening. And second is, I think, when I talk about the emergency, I think it's more about pre-positioning and preparing ourselves. That means what we call it the emergency preparations, expecting that what is coming, especially on the given trend, on the indicators of those changes. Thank you.
Okay, I will not add a lot of things because you already once again pretty well the topic. No, we already face the consequences of the climate change. So But it's not only the climate change, it's also the side effect or the reason of the climate change. Means very wild urbanization, increasing in density population, that will increase the contact between the vector, the pathogen, and the population. So we are just creating more and more contexts where you can have very severe outbreaks, and that can be a real issue for the next few years. Climate change will also create new endemic area, because you will have new area favorable to the vector, to the pathogen also, when in some other area, locally, vector and pathogen will not fit. But as you said before, now we have also to face people who are displaced by climatic change, flooding or kind of thing like that. And that means you also have change in population, where you can see non-immune population seeking refuge in endemic malaria place, for example, that can lead to also, a severe outbreak. And so all this change of population, it's something we have to be prepared. Another thing that we already know is, for example, invasive species, invasive vector for malaria. And one is specifically very worrying. And it's a vector who has the possibility to change the malaria profile, especially in Africa, where malaria was supposed to be more a rural disease. And now with this vector, we have to expect malaria outbreak in urban context. And that is something for coordination, for example, for MSF, where we have to be attentive about that, and we have to be prepared about it. So, it's epidemiology will be key. And I wanted just also to add something I forgot to add before. Community engagement is absolutely crucial. We didn't have time to detail that much, but it's really, really something important. We can't do anything without the community and the support of them. So just think about it.
Thanks so much. Now we're going to move on to we've been seeing some amazing questions come up in the Q&A. So thank you to everybody that's been putting the questions in there. As per usual, I don't think we'll get time to go through all of them, but yes, we will attempt to triage the most important ones, or the ones that most people liked. I'm going to throw this one at Letizia. All of these preventive activities require a good engagement from the community or parents. So some people in the audience would like to know, what is the advice on how to assure and work on that really well? Because there seems to be this impression that maybe we keep failing on this aspect.
Thank you for the question. That is indeed a key point. Indeed, we have quite extensive, let's say, health promotion activities, but the point is this enough? So maybe a reflection is, when we plan an intervention, should we actively involve members of the community, maybe in our planning? Should we ask first their opinion, and then work with them all together? Because indeed, if we want to reach a high coverage, we cannot reach without the community. And our intervention has also to be explained why we do the intervention, because the added value has to be fully understood. We are maybe providing some drugs to children, or we are spraying the houses. So it's not so obvious to let people enter in your house if the benefit is not so clear. So my suggestion would be really to include the community from the beginning and work with them in the activity.
Yeah, great points. Next question. This one's more about sort of the multiplication of various strategies for malaria prevention and control. We have someone in the audience who's wondering, considering that WHO guidelines extend these prevention recommendations to more countries, let's take, for example, SMC, which seems to be extending to more and more countries. Will it be possible to implement all of these things in the WHO guideline? And more importantly, what are you seeing for the future? I'll probably invite Letizia to answer that one with Kike.
Yeah, I think indeed the new WHO guidelines are giving more flexibility indeed, because probably before they were a little bit too strict as rule to be fully implemented in the field reality. However, I think the main message is always to look at the local context and to look at the epidemiological profile in order to choose the best preventative package. Not everything can be put together, let's say, but for example, seasonal and perennial transmission for the different SMC can be indeed applied in seasonal transmission. However, different maybe IRS and chemoprophylaxis, or so integration of different preventative package, that's a key point. But I would always look at the local profile in order to tailor the intervention. Maybe Kike has more input on this.
No, it's exactly what you say, and it's providing the National Malaria Control Program some ownership on the decisions of what is taken. Very quick example is IPTi, which is a formal recommendation since 2010, but because it has the caveat of saying if there are more than 50% quadruple mutations in the SP resistance marker, you shouldn't use it, because nobody looks at this at the national level, nobody implements this. So if you have rules, as in the past, which are so stringent that forbid their formal application, then there is no way to move these things forward. And the current new guidelines, what they offer is this degree of flexibility for national malaria control programs to decide what they want to use, how they want to combine it, and how best to approach their specific malaria problem within their borders.
Thanks so much. Now, we are running a bit out of time. We'll aim to attempt to answer the other questions that we'll put in the Q&A. Some of them may have actually been answered over the course of this session, but we'll aim to do them by in the Q&A box. So apologies for anyone that didn't have their question answered, but they were all great questions. Next, we promised that we would give you the answers to that online poll. So I'm hoping that we can show that to you on the screen. And then just to recap, so the first question was, how many cases of malaria did MSF treat in 2021? So the correct answer was between 2.5 to 3 million, which is quite enormous, isn't it? Now, the second question, what does the term IPTi stand for? I think everyone probably knows that by now. We've discussed it a lot over the course of this session. So it's intermittent preventive treatment in infants. So it's the last option. And finally, the third question, which had an answer to it, was how often can you wash a mosquito net? Is it each month, anytime I need to because it's dirty, or never? So it's the middle answer. So it's anytime you need to because it's dirty. Just the usual hygiene rules. And yeah, the final question, as we mentioned before, there's no correct answer. It was just to have a bit of an understanding about what you have. So just very rapidly before I hand over to Joanna, I was taking a few notes for the wrap up, but yeah, I think I'll start with in terms of malaria interventions, what we should be thinking about in our project. So some of the key points are look at your target population. Also ensure that the basics are done and that they're done well. well, and they're done at the community level. So access to RDTs and ACTs. You know, we might not be able to do complex community activities if the security context is unsuitable. So you have to look at security for your teams, but ensuring the basics and doing it well, and also integrating epidemiology. In terms of prevention, what should we do when we're actually starting an actual strategy, and how we can use existing opportunities to integrate? We had so many great examples. We had, you know, integrating malaria control into EPI clinics, ANC. We heard about post-discharge nets and even the new innovation of post-discharge prophylaxis. We've also heard about the importance of not only community engagement for any of these preventive activities, but also at the very other level is having this higher level political engagement, working with our Ministry of Health colleagues, and, you know, really ensuring that our strategies are working in synergy and not in silo. For the challenging settings in emergency context, this was one of the questions that came up in the Q&A, so hopefully this answers it. Just to recap, but, you know, we heard about how one of the most important things is to really acknowledge the good things that are working in the project and continue them, but also if you're wanting to introduce something new, do a pilot, look at your epidemiology, look at where there's gaps. There might be gaps in other activities that are done by other actors. And then also really tailoring it to the local context. And then in terms of innovations, we had, you know, we heard about mass drug administrations in Ebola, in flooding, and these are ad hoc interventions. And then also using that opportunity at any chance we can with any child health intervention to give them vitamin A, albendazole, give them catch-up vaccines. And this beautiful term, I'll end with this. This is Dr. Paul Sondo's words, that malaria and nutrition are the perfect marriage. So I want to thank all of the participants today. And yeah, I want to thank all of the participants for being so great today and having this really wonderful discussion, and for all the amazing questions in the chat. Okay, I'll hand over to Joanna.
Thank you very much, Sashveen, for facilitating such a fantastic, fascinating and multifaceted session, and so great to hear from so many different perspectives, combining the latest in research and development, vector control, representatives from our operations department and medical department, and of course our frontline teams in the field. And I think your summary really, it applies to so many of our issues, you know. Looking at our target population, getting our basics right, looking at our epidemiology, and maximising our interventions with every contact with our patient. So thank you. I'm sure there are many, many more questions and a lot more discussion that could be had, but the malaria panel will be available during our conversations over coffee break for all your questions. We're going to move now to our PED talk, which is entitled Time for Action, Climate Change in the Humanitarian Sector. And I'm delighted to welcome Rita Issa to give today's PED talk. Rita is a British Lebanese primary care doctor and PhD fellow under the Critical Decade for Climate Change program at the University of East Anglia, where she researches the mental health impacts of climate change, and a research fellow in the Climate Change, Migration and Health at Lancet Migration. Rita previously worked with MSF and the WHO Climate Change Department, as well as several other organisations. She co-founded a number of advocacy organisations, and her contributions to the field of climate change and health were recognised as London's Public Sector Individual Changemaker of the Year 2022. It is my pleasure to welcome Rita.
It was getting hotter. Frank took a deep breath. It reminded him of the air in a sauna. He looked at his phone, 38 degrees, humidity about 35%. A few years ago, it would have been among the hottest wet bulb temperatures ever recorded. Now, just a Wednesday morning. The opening chapter of Kim Stanley Robinson's climate fiction novel, The Ministry for the Future, paints a harrowing scene where faced with an extreme heat wave, residents wade into the city's lake in an attempt to find respite. Many die. For the humanitarian worker protagonist in the book, the event is deeply traumatizing and it changes the course of his life forever. What is described is sadly not fiction, an increasingly likely future, and for some, experiencing flooding and heat waves in Pakistan or wildfires in Spain, Portugal, and the US, a very tangible present. But what does this mean for us as humanitarians? This relationship is twofold. We know that climate change and environmental degradation impact and necessitate humanitarian response. And meanwhile, humanitarian response also has impact on climate change and the environment. But let's look first to how the climate crisis is a humanitarian one. In the past 10 years, climate and weather-related disasters have claimed more than 400,000 lives. It's affected 1.7 billion people, and it's displaced an average of 25 million people each year. And as I'm sure we're all aware, we know that these risks are rising with more frequent and more intense weather events, including droughts, flooding, and tropical storms. The humanitarian consequences, whether these events are slow onset or rapid and extreme, are major, causing death, disease, and destruction, large-scale population displacement, public health emergencies, and they drive conflict. And so by 2050, 200 million people could require humanitarian aid every year because of climate-related disasters alone. And while climate change hits everywhere, it's always the most vulnerable people who are disproportionately affected, those who face multiple other threats, including being disabled, older, children, women. And for people who are displaced, many move into areas which are climate hotspots, at risk themselves of flooding, heat waves, and drought. And so it's important to us working in this sector that we know the risks. There is a sizable body of knowledge on how to minimize the human impact of many of these events through resilient work, through disaster risk reduction, and by increasing international capacity to cope with disasters. However, as future disasters related to climate change get bigger, happen faster, and affect more people, our existing knowledge and capacity for response may not be enough. There are three types of humanitarian events we can feasibly expect. Known disasters, those of which we already have extensive experience and understanding, but might have new characteristics. They might be greater in scale, in frequency, they might be impacting new geographies, or there might be concurrent disasters alongside them. We might also experience imperfectly understood disasters, those that are in some respects developing along familiar lines, but they may present new or unexpected features, such as hurricanes or cyclones that develop much more quickly or with a different trajectory to usual. And then we have the unknowns, things which might be completely unprecedented, so extreme heat waves. And while we know about heat waves as a hazard, they haven't typically required a humanitarian intervention. And so how do we adapt and respond to that? We also may experience cascading or new disasters, complex disasters that might have unpredictable impacts across economic and social structures. And arguably, we saw this with COVID-19. Countries failed to use the lessons learned from previous coronavirus epidemics. These are events that are relatively well understood, and we were unable to contain the disease, which led to a global disaster with a plethora of socioeconomic consequences. And so while the lessons that we currently have from humanitarian action can be expected to hold good for known disasters, these are far less likely to be reliable or useful for imperfectly understood disasters, and certainly not the unknowns. And so what do we need in that scenario? We need to consider how we adapt and respond. Part of the way that we do that is we identify at-risk regions such as densely inhabited areas or delta regions. We need to develop our ability to design and implement a range of program types: resilience, disaster risk reduction, anticipation and response, and consider new programmatic responses to things such as heat waves. We also need to center constant learning, monitoring and evaluation, updating our knowledge, and being able to be flexible and agile in our thinking. And we really need to embed, as has been said for many years, but even more so at the moment, work across sectors. Health, yes, but we need to consider how that fits into shelter, urban planning, water and sanitation within, for example, the context of heat and heat waves and other extreme events. But climate and weather-related disasters are not inevitable. We are still within this critical decade for climate change where there's still some scope to act. And so we can mitigate the worst of climate change, both by reducing emissions and waste now, and by considering sector-specific preparedness. First and foremost, the humanitarian sector has its own footprint. Much of that comes from procurement of goods and other services in the supply chain, and also through forms of transport and transporting goods, transporting human resources, so taking planes and other forms of transport. The sector itself needs to measure, report, and set targets to minimize the carbon and waste footprint. And we know that MSF has done this already, pledging to reduce our emissions by at least 50% compared to 2019 levels by 2030. One of the ways that we can support this is by really thinking about how we localize and decolonize action. And this has been very much in the sector and in discussion over the past 5 to 10 years. We can do this by promoting context-specific and localized knowledge, supporting local people and increasing local capacity to better understand local vulnerabilities and enable local resource mobilization. And this also reduces unnecessary travel and helps to support decolonizing the sector. It's also a matter of resources. We have the data that we need to be able to predict what might happen, but we need to consider how we use it to support catalytic financing and localized resource mobilization that can be triggered before an extreme weather event even happens to ensure that it doesn't become a disaster and to preserve lives and livelihoods. And at MSF, we're also in the business of témoignage. We must consider how we individually and as a sector bear witness to the climate crisis, paying attention to disproportionate impacts felt by vulnerable groups and aligning diverse experiences with humanitarian, operational, and advocacy goals. And we can also think about how we climate-proof existing projects, remembering that humanitarian response itself can damage the environment, as we've seen with mass deforestation, such as in Sudan, when seeking cooking fuel. And this image shows the Minawa refugee camp in the Cameroon, where tree planting can contribute to livelihoods and nutrition. It can help stabilize the soil, can help retain water in the ground, and also provide shade. And we know that other activities can support both efficiency gains alongside other health, social, and financial co-benefits. And so while the climate crisis has all of the ingredients of a crisis, it's also a brilliant and unique opportunity. The pressure of climate change on the humanitarian sector will shape where the sector evolves into for the next 50 years. This is an evolution that's probably overdue. And so now is the time to take stock, think flexibly, adapt and mitigate, and continue to provide necessary care and resources to the place that need it most within this new paradigm of planetary health. Thank you.
Thank you, Rita, for that quite articulate presentation. Rita will be available during the conversations over coffee in just a moment for any questions. So that concludes today's session. Prevention is better than cure. It's not a new concept. The phrase is often attributed to the Dutch philosopher Desiderius.
Self-outlook at needs your attention.
Sorry. I'll start again. The phrase is often attributed to the Dutch philosopher Desiderius Erasmus in around 1500. But yet for MSF as an organisation, it challenges our very identity. We've long positioned ourselves as a humanitarian organisation that focuses on emergency response and providing healthcare in response to conflict, epidemics, famine and natural disaster. That is changing. Prevention is about tackling the upstream causes of ill health. And so we are challenged to think of novel ways that focus on local eradication, prevention, and detection and early management. In our oral presentations, we heard about predictors of wasting in MAMI patients, a vulnerable group meriting further research. The quality of our interventions was considered in one presentation that focused on addressing systems issues using simulation to improve triage processes, and another that explored community and caregiver perspectives of seasonal malaria chemoprevention. And we heard some promising results regarding early diagnosis of sickle cell disease, a common and devastating diagnosis in many places in which we work. Looking externally to collaboration with institutions is one way to improve the care we provide to our patients and set higher standards of care. And we heard about a great initiative that is harnessing the expertise of our local partners. We just had a fascinating session and panel discussion on strategies to prevent and control malaria, looking beyond management of severe cases that continue to have devastating complications in our paediatric patients, and heard about some great initiatives focusing on disease prevention, vector control, the role of chemoprophylaxis, mass drug administration, rapid diagnostic tests, and finally the potential for vaccinations. This session also highlighted the importance of capitalising on opportunities for prevention at every contact with our patients and exploring synergistic interventions that can be more efficient and not just have a combined effect, but multiplicative benefits. And the session reinforced that, as for so many interventions, community engagement is crucial. And we had some thought-provoking presentations on the role of climate change on human health. Zulfikar Bhutta set the scene this morning by articulating the inextricable links between rising global temperatures and the effect on the environment. Climate change results in degradation in the quality of our soil, air, and water, and this has major direct and indirect effects on human health. We're seeing an increase in vector-borne diseases, respiratory allergies and asthma, malnutrition and diarrhea, mental health problems, and population displacement impacting our health service delivery. And those that are most affected are those with inherent vulnerabilities, the very populations in which MSF intervenes. And these issues disproportionately affect our women, newborns, and children. This was brought home in our final session today. We cannot escape the effects of climate change. We need to continue to rise to our charter to respond to the health needs of the most vulnerable and marginalised, whilst minimising our own environmental footprint. The climate crisis is a health crisis. The climate crisis is a humanitarian crisis. I'd like to thank you for your participation today. We've reached the end of the second day of our program. And if you missed yesterday's session, the recording is now available in English and French. We'll now move to our break with conversations over coffee. And it's going to be a very hard choice because there are 3 sessions on offer. The whole of the malaria panel will be available in one room. We'll have a session on climate change with Zulfikar Bhutta and Rita Issa, who will be available for discussion. And in our third session, we have Inma Carreras, who is available to discuss local partnerships. To access the conversations over coffee, you can click on the banner in the auditorium, just below the auditorium, or you can go to the agenda and click on the sessions there. Remember to make use of the other fantastic spaces available on the platform, particularly the networking lounge, where you can connect with your colleagues. There's also the resources library, there's the booths and posters, there's a possibility to reach out and chat with other participants, and there's a photo gallery. So particularly if you're joining the conference in a group, we'd love to see a picture of you all together. Thanks again, and look forward to having you back for tomorrow's session on Neglected No More, which will be chaired by Daniel Martinez.